I want to welcome everyone out to the first Behavioral Health Reform and Innovation Commission meeting. We're excited about this opportunity, excited and appreciative of Governor Brian Kemp for endorsing and supporting this effort and leading this effort. Thank you to Speaker Ralston and to Lieutenant Governor Duncan and our Chief Justice of the Georgia Supreme Court for their appointments. I've told several of you in the room this morning, and I truly believe this, if there's anyone or any group that can solve a problem or improve this issue, it's going to be this group in this room. In my time, almost 30 years now, working in different government levels of service and being involved in different issues, I don't think I've ever saw a better group that's been formed by our chief elected officials in the state than the group we have in this room today. So thank you for being here. I know each of you are very busy people, but you all bring a specific level of expertise to this topic, and I think you're going to be very valuable in solving some of the problems we're going to talk about. This commission was set up through legislation. It's codified into the law. It's a 4-year commission that ends June of 2023. This commission's work, a lot of this commission's work will be done in subcommittees. Later today, we'll be appointing some of those subcommittee chairs, and then I will be sending out an email over the next week or so with the subcommittee assignments. But we're going to be talking about some very difficult, very challenging issues. It'd be difficult to do it in a room with this large a number of commission members, so we're going to break this up into bite-sized pieces, so to speak, and do a lot of the work in the subcommittee level. I'm excited about our subcommittee chairs that we'll talk about a little bit later. They bring a great deal of expertise and leadership to their specific areas and their topics, and I feel very confident that we're going to have great success as we move forward. As we move forward, we will be, as you know, we're under a settlement agreement with the Department of Justice, and in the legislation, it requires that all of our agendas be approved by the Governor's Executive Council. So as our subcommittees and this commission, full commission agendas will have to be approved in that way ahead of time. So our goal moving forward would be that our subcommittees would probably meet on a monthly basis more often if the subcommittee chairs deem it necessary, and then the full commission would come together probably every other month. I know that you have busy schedules, so we'll be working to get some dates out as soon as possible so that you can set that aside on your calendar for the full commission meetings. And I know subcommittee chairs will also coordinate with their smaller groups to find times and locations to meet that's convenient for their subcommittee. So again, thank you for your service. I think it's going to be important as we get to know each other that we go around the room. It's going to take a little bit of time, but I think it's important for this first meeting that we understand who we all are. And if you would, when you introduce yourself, if there's any specific areas around the behavioral health conversation that you work in, let us know what that is. And also, if you don't mind, just tell us who appointed you to the commission. And I'll start. I'm Kevin Tanner. I serve in the General Assembly, served in different roles in that capacity. I chair the Transportation Committee in the House. I've also served on and chaired several special committees in the General Assembly since my time in office. I've also spent 20 years working and running a law enforcement agency. I have a master's degree in public administration, and I will be the first to admit I am the least among this group. I tell folks I'm not the smartest guy in the room, but I'm smart enough to surround myself with the smartest folks, and I think that's what we have today. I'm a process guy. I'm an organizer, and my job here is to corral the chaos that can be this large group sometimes and get us to the end game, which is to really lead the nation in this conversation, and I'm confident that we can do that. I'm always available to you. If you don't already have it, I'll make sure Chelsea, and Chelsea, if you would raise your hand. Chelsea is my admin. You'll get to know her well. She will send out my cell phone number, so anytime you need anything, please let me know. We're all going to have a lot of different ideas, but one of the things that we're going to be, and we met with the governor's office, one of the things I assured them is that we were going to vet everything through our subcommittees. So I know we're going to have ideas, solutions, but we have to have a controlled way of bringing all that together. So we're going to run everything through the subcommittee process and then up to the full commission as we bring everything together in a controlled way. We also have Betsy here. She's from Legislative Council. She ultimately is responsible for anything that results in legislation, for drafting that legislation. She's our advisor from a legal perspective for the commission, and I appreciate Rick assigning her to this commission. Michael's also here from our research team. He's been assigned to staff this commission. I appreciate his work and look forward to continuing to work with him. So we got a good group from the administration side to help us. I believe Ryan is also here. Where Ryan? There you are. Sorry, Ryan's from the governor's office, and he heads up the policy team relating to this conversation. So appreciate all the work that he's already done in healthcare with the waiver request, and look forward to continuing to work with him in that office as we move this conversation forward. And again, thank you for Governor Kemp's leadership on this topic. With that, I'm just going to start. I know we have a few people that will still trickle in. Dr. Sarah Vinson, I don't think's got here yet, but we're going to go ahead and get started. And like I said, if you would, just introduce yourself, tell a little bit about yourself, and specifically around what you do in this field. And I'm going to sit down, and we'll just go around the room. So go ahead.
Well, my name is Dr. DeJuan White. I am primarily work at Grady Hospital. I'm the medical director of the psychiatric emergency services there. Also assistant professor at Emory University School of Medicine, where we train the trainees coming in through there. So see quite a bit of the deficits or lack of care and people coming in on involuntary holds to our services. In addition to my training in psychiatry, I have also been boarded in internal medicine and also forensic psychiatry. Had opportunity of being trained here at Georgia Regional Hospital as part of the training, and work at 10 Park Place, which is our outpatient mental health facility, providing primary care there. So working in the integrated behavioral health care setting and making sure our patients with behavioral health conditions get the appropriate medical care as well. Appointed by Governor Kemp, I'm sorry, missed that part.
Good morning, I'm Michael Yokelson. I am the Chief Medical Officer at Shepherd Center. I'm a neurologist and a physiatrist, physical medicine and rehab specialist by training. I'm a Navy veteran. My clinical practice is in traumatic brain injury. I see patients in our military program, our veterans with both TBI and overlapping PTSD, as well as depression, anxiety, and many other mental health issues. And I was appointed by the governor as well.
Good morning. My name is Mike Boggs. I serve as a justice on the Georgia Supreme Court. Prior to that service, I served as a judge on the Georgia Court of Appeals. Prior to that, a Superior Court judge down in the rural part of the state in the Waycross Judicial Circuit, where I developed and presided over our courts and our circuit's first adult felony drug court program. Prior to that, I served in the legislature, and I was a private practicing attorney. From 2013 to 2018, I co-chaired Governor Deal's Criminal Justice Reform Council, which I'll speak about a little later. I'm honored to be with you. I was appointed by Chief Justice Harold Milton, one of 3 judicial appointments to the court, or to the commission. Thank you.
Good morning. My name is Jason Downing. I was appointed by Governor Kemp. I actually serve on the State Board of Education, and I was appointed by the governor back in April of this year to that. Prior to that, I was elected to the Bibb County Board of Education, where I served from 2013 to 2017. Actually, Judge Harris swore me in, so it's kind of special to be sitting beside of 2 judges. It's a little unnerving as an attorney to be doing that, but my day job, I am a private practicing attorney, actually in-house counsel for an insurance company, Allstate Insurance Company, so you're in good hands.
I'm Sarah Harris. I'm the judge of the probate court in Bibb County. I handle a lot of civil commitment proceedings, so I have a background in mental health going all the way back to my private practice, where I focused in elder law. I was a court-appointed attorney for most of the civil commitment cases in our area, and I have been the past I am the past president of the Probate Council of Judges, and I'm delighted to be here. And I was appointed by Justice Melton as well.
Good morning, I'm Mary Margaret Oliver. I was appointed by Speaker David Ralston. I am a member of the House of the General Assembly and have served in both the House and the Senate for a long political career. I've been active in a good number of the legislative efforts around mental health and children's services in the General Assembly. I have a full-time law practice in Decatur for several decades and have served as county administrator and county conservator for DeCal with a lot of law practice around mentally ill adults, conservatorships who've been individuals who in many ways have been taken advantage of by the system and not receiving services. I testified in a murder case of one of my wards last year who was murdered by his caregiver, according to the jury verdict.
Hello, I'm Nora Haynes. I'm originally from Waycross. I've been in Atlanta for about 30 years. I was past president of the National Alliance on Mental Illness, NAMI, Georgia. I've also been involved in CIT, Crisis Intervention Team, which is law enforcement training, since 2004. I was also on the International CIT Board. I'm very proud and happy to have been appointed by the governor, and I'm really excited and hopeful that we can improve the system. I have a son who has been in the system now since he was 19. He's now 43. So I have the lived experience of the mental health system, and I am really anxious for us to all come together and figure out how to improve services for our most vulnerable citizens.
Thank you. I'm Senator Renee Unterman, and I was appointed by the Lieutenant Governor Jeff Duncan. I appreciate the appointment. I've been elected almost 32 years now. That's hard to believe. But as an elected official, I have focused on health care and specifically behavioral health care.
I'm Andy Hester. I'm a sheriff down in Turner County. I spent 29 years in law enforcement. This will be my 8th year as sheriff. I graduated high school and went straight into law enforcement and been dealing with all aspects of it ever since then. Moved up through the ranks as chief deputy and dealt with a lot of the issues that the sheriff's office has to face with mental health. I sit on the board of the Georgia Sheriff's Association, and I have a wife and 4 wonderful children, and at the end of the day, I feel like I need some help. But, I'm glad to be on this. Jeff Duncan, our Lieutenant Governor, appointed me, and I'm proud to be so.
Good morning, my name is Brent Weaver. I'm the Chief Judge of the Appalachian Circuit at Fannin, Gilmore, and Pickens County. I have been operating accountability court since 2002, including Veterans Court, Felony Drug Court, and Mental Health Court. Prior to being a Superior Court judge, I was a Chief Juvenile Judge and also had a private practice. I was appointed by Speaker Ralston.
I'm Don Hogan, State Legislator, and I live on St. Simons. Been there 50-something years. I retired after about 34 years of community service with the Gateway program down in that area, Community Service Board. I was involved in the deinstitutionalization process of moving everybody out of the institutions to the communities, set up group homes for the development of disabled, training centers and so forth down in about 8 counties in our area. So I've got a vast amount of experience in working in the communities. Don't know much about the institutions, but other than moving people out. So thank you. And Speaker Ralston appointed me.
Good morning. I'm Cindy Levi, and I was appointed by Lieutenant Governor Duncan, representing the Community Service Boards, the Public Safety Net. Working with individuals with behavioral health diagnoses and intellectual and developmental disabilities has been my life work, particularly those individuals with limited options that are available to them, those that don't have insurances. I am very proud of the fact that I work very closely with our law enforcement and NAMI for training of law enforcement in Northeast Georgia. As the CEO of Avita Community Partners, I have been in that position for the past 8 years.
Good morning. I'm Joe Bona. I'm a psychiatrist by training. I was appointed by Governor Kemp. I have an MBA. I am the CEO and the Chief Medical Officer of the DeKalb Community Service Board. I've been practicing 35 years now, and in multiple different settings. I'm an adjunct professor at Emory and at Medical College of Georgia, and I've been involved here in Georgia for now 23 years, seeing the system both from the academic side, from the private side, and now from the public sector side. So I'm excited about what we can do to transform this system.
Good morning. My name is Kim Jones. I'm the Executive Director of the National Alliance on Mental Illness for Georgia. Speaker Ralston appointed me, and we're so grateful to be here. We represent over 18 to 20 communities across the state who have family members and people with lived experience. I come to you with 15 years of experience working with people with disabilities, including mental health. My previous work was with Goodwill of North Georgia, and my background is social work.
Good morning, I'm Gwen Skinner, and I'm the Operations Vice President for Devereaux Advanced Behavioral Health, where we serve a range of people with mental illness, everything from foster care to psychiatric hospitals. I have responsibility for Georgia, Florida, and Texas. Prior to that, I was the Director of the Division of Mental Health, Developmental Disabilities, and Addictive Diseases. And then prior to that, I was Deputy Commissioner of the Department of Juvenile Justice with responsibility for all of their operations. I'm a nationally certified school psychologist and also a licensed marriage and family therapist, and am very passionate about what we're about to work on.
Hi, I'm Karen Bailey. I'm the Director of Forensic Services for DVHDD. I'm a forensic psychologist, been working for 30 years. Mostly deal with people with mental illness who cross over into the criminal justice but don't go into the criminal justice system. Incompetent stand trial, not guilty by reason of insanity. And that system has had a huge increase over the years from being a very small system to encompassing several thousand people now. Work closely with the Superior and State courts, the sheriffs, and done some national work in that area. It's appointed by the governor.
Okay, great. Good morning. My name's Wayne Seinfeld. I was appointed by the Lieutenant Governor Duncan. I am a Senior Vice President with the Tanner Medical Center. It's a 5-hospital center in West Georgia. I sort of had 2 careers. The first was in education and started out as a social worker, a truancy officer, and director of counseling for the city schools before I came over to Tanner, a nonprofit hospital system, to rebuild behavioral health. And that was about 20 years ago. And now we have a 92-bed behavioral health hospital that takes children all the way up through an acute unit. We also manage a 52-bed inpatient unit at Floyd. We're in 16 counties. We're in 50 schools. We're in 2 universities. And I'm also happy to be here as well. I also chair the Psych and Substance Abuse Council for Georgia Hospital Association, where I'm on the board. And I'm also on the American Hospital Association Board, Southeast Planning Division.
Okay, good morning. My name is Brian Amaro. I'm a Superior Court judge in the Flint Judicial Circuit. I was appointed by Chief Justice Melton, the Georgia Supreme Court. I come to this from a background as someone who started a drug court back in 2008 in the Flint Judicial Circuit. Also presided times over the mental health court in the Flint Judicial Circuit. Started the PAC program, which is a Parental Accountability Court program. I'm a big believer in everything that Brenda Weaver and Justice Boggs has done in terms of criminal justice reform over the course of the last 8 years. And so it's that background that really brings me to this. I was also the chair of the statewide committee on mental health and local jails for the Council of Superior Court Judges, and I'm currently the president-elect of the Council of Superior Court Judges. Thank you.
My name is Miriam Shook. I am an elementary media specialist from Oconee County. I have 16 years of teaching experience, and I'm looking forward to seeing how we can work together to support Georgia students.
Dr. Fitzgerald?
I think I got the mic now. My name is Tyrone Oliver, the Commissioner of the Department of Juvenile Justice. I come to you from the background of law enforcement. I spent over 20 years in law enforcement, and my last 3.5 as police chief in Social Circle, and I'm just happy to be a part of this commission.
Good morning. I'm Stan Cooper. I'm actually sitting in for Commissioner Ward this morning. He's had some sickness in his family, couldn't be here, and he regrets that very much. But I'm a special assistant to the Commissioner of Corrections right now. Prior to that, I served as Director of Probation Operations for 6 years and had the opportunity to work on criminal justice reform with Justice Boggs and others in this room for all the years there, and along with the accountability courts as far as starting up mental health courts, drug courts, and those things. So happy to be here this morning.
Good morning. I'm Frank Berry with the Department of Community Health. It's a small world after all. I used to work with DBHDD, and to be back here is wonderful. So, Commissioner, thank you for hosting us very much.
Good morning. I'm Michael Noel, Commissioner of the Department of Community Supervision, which is responsible for supervising adult parolees and probationers in the state of Georgia. Prior to our agency being created 4 years ago, I served 5 years as Executive Director of State Board of Pardon and Parole, and then 22 years with Department of Corrections in numerous capacities. So, pleasure being here.
Good morning. I'm Dr. Brenda Fitzgerald. I trained at the Emory Grady system. I was appointed by the Lieutenant Governor. I have been the former State Health Officer and head of the Commissioner of the Department of Public Health. I've been the Director of CDC, and now I am currently the chair of a group that has come together to unite the private and the public sectors. It's called Resilient Georgia, and I was appointed by the Lieutenant Governor.
Good morning. I'm Tom Rollins. I'm an ex officio member as the Director of the Division of Family and Children Services. Of course, we at DFACS serve a significant number of children and families with behavioral health and developmental disability issues. Many of these children, of course, experience trauma. I kind of got interested in this area when I was a juvenile court judge about 20 years ago. Noted that so many of the children who were coming into our juvenile court system, as well as their families, had behavioral health issues, and so we created a intensive in-court treatment team for that, and it's been an interest of mine ever since, so I'm very glad to see this commission come together.
I'm Dr. Sarah Vincent. I'm a child and adolescent, adult, and forensic psychiatrist. I'm an associate professor of psychiatry and pediatrics at Morehouse School of Medicine, and have done public sector children's mental health work in Georgia for the past 10 years, whether that was integrated care, working at juvenile justice facilities, or at county health departments.
I think we got everyone. Did we miss anyone? No, we had 2 members that I know of that were not able to be with us today for different reasons, so we'll catch them at the next meeting. But again, I appreciate it. All of you can see we've got a very diverse group of experts in a lot of different fields, all coming back for the same purpose, and that's to help work on this issue. A couple of administrative announcements. One, I know it's a little aggravating passing the mics down, but if you going to ask a question, you're going to speak, please do that in a microphone, just because we do record. All of our meetings are public, and they are all recorded, so if you could speak in the mic, if not, it doesn't pick up for us with the camera. And then a couple of other things. You should have all the commission members in your packet. You should have a Georgia General Assembly citizen member sheet. That needs to be completed if you're not a legislator and you're not one of our ex officio members of the state. But if you're a citizen member that's been appointed by one of these individuals, fill this out for us. There's a per diem for the commission meetings and the subcommittee meetings, but our office has to have that completed before they're able to process that payment. That should be in your folder. There should also be a Behavioral Health Innovation Reform Commission information sheet. That's for Chelsea. That'll give her all the pertinent contact information. If you would complete that and leave it with Chelsea today before you leave. Also, I think everyone in the room is being asked, if I'm not mistaken, to fill out the confidentiality form by the Department of Behavioral Health and Developmental Disabilities. So for the commission members, there's one of these in your packet. Please complete this. For the public, they're in the back. So if you would, before you leave, complete this and leave it for the department today. Again, it's a confidentiality agreement that you have with the information. We're talking about a lot of sensitive topics, and that needs to be handled in the appropriate way. I think that is all the announcements, and we're going to go ahead and get started this morning. Someone already mentioned, and I want to echo that. I want to thank Commissioner Gigi Fitzgerald and her staff for hosting us today. Appreciate Doug and the folks here, Dr. Lee and others here at this facility for the work they did to set up the room. We also, for commission members, at the conclusion of the meeting today, there'll be a tour of the facility. That will be just for the commission members. We'll do that in 3 groups, and we'll get some more information from staff as we move toward that later this afternoon. We'll also have lunch for the commission members that'll be served today, and appreciate John Bozeman and others helping us with that today. So at this time, we're going to call up Commissioner Gigi Fitzgerald, and again, thank you for hosting us, and great staff that you have. It's just been very accommodating, so thank you.
Thank you, Mr. Chairman. Well, good morning to a packed house. As mentioned, my name is Judy Fitzgerald. I'm the Commissioner of the Department of Behavioral Health and Developmental Disabilities. I'm humbled to be in a room full of experts, some of whom are new to the game, but some of whom I've known for a long time and feel like we've been in a fight together for a long time. So it's pretty rewarding to have an opportunity to start a 4-year conversation together. I want to echo Chairman's compliment to our team. Dr. Lee, who's probably adjusting temperature in the back of the room, give a wave. Many of you know Dr. Lee is the administrator of Georgia Regional Hospital here in Atlanta. So it's fascinating as we begin to talk about Georgia's behavioral health system, how many folks have probably never set foot on state hospital property, and this is a really critical part of our safety net work. So hence, we're excited excuse me, to offer the commission members an opportunity to tour and begin to make real some of what's happening in our state. So thank you, Mr. Chairman. Glad we got a chance to introduce ourselves to one another. And I want to thank the leadership of the state. So I've been around long enough to know that once upon a time, if you had a behavioral health meeting, you'd have to entice people with lunch to get them in the room, really, because for a long time, people didn't really want to talk about mental health and substance abuse disorders out loud. My own experience is they always wanted to talk about them, but hardly ever out loud. So here we are. With the governor, the lieutenant governor, the speaker, and the chief justice all saying, let's appoint our best people to come together and solve one of the biggest challenges that we have in healthcare in our state. And by the way, folks like this, groups like this are happening in several states across the country because we are absolutely not alone in some of the challenges that we're facing. So, but like you, Mr. Chairman, I'd like to show folks how Georgia plans to get ahead of the game. And so we get underway. So this morning you'll be hearing from a number of subject matter experts. Several of them are from my team at the Department of Behavioral Health and Developmental Disabilities. You'll also hear from Justice Boggs and Cindy Levi, really important members of our state, important leaders and subject matter experts. I do want to let you know, so here's who you'll be hearing from on my team. Dr. Emil Risby, who's our medical director and oversees our hospital system, will share some information. Monica Johnson, who's the director of our Division of Behavioral Health Services, and some of her team members. Dante McKay will give you an overview of the children, young adults, and families work in the department, and Cassandra Price will share with you a perspective on addictive diseases. You'll also have an opportunity to hear from Amy Howell, our general counsel, who will tell you a little bit about the status of the settlement agreement with the Department of Justice. So make yourself comfortable. You're going to hear from a lot of experts this morning, and then, of course, we'll hear from Cindy Levi and Justice Boggs. And so there's a lot of information coming your way. And really, the idea today, the task that we had today is starting a 4-year conversation. right? Did you know you signed up for, for a 4-year conversation? What's really good about that is many of you, and I could ask for a show of hands in the room if you've participated in a study committee, a commission, a task force, whose job was to try and fix mental health or figure out what's wrong with the criminal justice system and the intersect with mental health, or really understand mental health as part of healthcare. Many of us have had those opportunities. I don't think there's ever been a time where we in the state of Georgia said the leadership of this state is going to get serious and begin a 4-year conversation. So the task of our presenters this morning is really just to begin to set the stage, begin to share some common language, and understand what different perspectives are of the system here in Georgia. A good part, certainly when you're hearing from DBHDD, you'll be hearing about the public safety net. That's our role, that's our responsibility. But to be clear, that's only one part of a very complex behavioral health system in the state of Georgia. And in fact, when asked to say, Judy, could you provide an overview of Georgia's behavioral health system? Well, there's not a single behavioral health system. What you all know is there are many behavioral health systems, services, supports, gaps. We're here, I think, as a commission, really to have the opportunity to look at all of those. And I think a really important point as we start, if asked, how is the system doing? What is the system? It really depends on the seat that you sit in, how you even think about who the system is, who it's not, how it's performing. So I really invite everyone to keep that in mind, that the opportunity for the commission is to think bigger, is to learn from one another about what perspectives look like if you sit in a different seat. Hearing from people with all kinds of expertise and certainly people with lived experience, and being able to hear what it sounds like from the different seats we sit in, that's going to be the power, I think, of this commission, is to learn from one another. So I'm excited about that. So I thought, you're going to hear from so many experts. I'm not here to tell you what it is or how it works. What I think is really important is to understand some of the context and the history, and to ask the right questions as we go forward. So, as a person who's been at this for almost 30 years, and it's humbling. Many of you know this story, but I'm a social worker, proud of that, graduate of the University of Georgia, and my thesis was on the reform of the public mental health system 28 years ago. And here we are again, tackling some of the same challenges with a lot more complexity. So I know what brought a lot of people into the room and to this table, because this is a popular commission. It was hard to get on. You had to really want to be, I think, a part of this conversation, so we're thrilled that you are. People, a lot of times their participation is born out of frustration and feeling like there's not enough happening, it's broken. What I hope we can do is also take a look at things that have improved, where we've made progress, because we are in a much different place than we were when I wrote my graduate thesis 3 decades ago. So, all right, I'm going to share a little bit of once upon a time and take you backwards a little bit in order that we can go forward and remind you of how things look, how things used to look, and how they look now, the old world view versus some of the current reality. And again, just to underscore that despite some of the frustrations we all share, we've made remarkable progress. But I think a really critical thing is to understand behavioral health as part of many systems, but first and foremost, as part of a healthcare system. So while deficiencies we experience touch many systems and many aspects of community life, in the end, the work that we do in behavioral health is really embedded in the healthcare system. So it's important to understand the massive changes that are occurring every day in healthcare. And so when I say, let's look backward for a minute in order to point forward, I'm not going to take you back to 1842. You know what that date is? That's when Central State Hospital in Milledgeville first opened. So to start thinking about how far we've come, but I will take you back just really over the last 25 years. You all have this presentation in your packet, but you can see all I want to do is contrast a little bit of where we used to be versus where things are now, some assumptions that folks have always had that have radically changed just in recent years. Really important one first, because as I mentioned, thinking about behavioral health as part of healthcare is really important. Once upon a time, in our lifetime, there was a real emphasis on physical health and mental health being two different systems. They were treated differently, funded differently, viewed differently. What we know now is those that are involved in the behavioral health system feel really strongly that behavioral health is absolutely essential to overall health. Once upon a time, there was a private system and a public system, and there were those state hospitals for those people. The reality here in Georgia currently is we have a very high rate of uninsured individuals, and so the lines are blurred between public and private. It's not quite as clear. I'll give you a good example. If you have a substance use disorder and you go through rehab and you have insurance, maybe the first time or the second time that's covered. By the time you need a third round of rehab, which happens with a chronic disease, you might not be an insured individual. So that line between there's public and there's private really begins to fall away. Another distinction used to be you were a payer or you were a provider. What you all know, if you read the newspaper, is every day healthcare is changing. There are mergers, acquisitions, organizations fold, they come together. Payers are providers, and providers are payers, and healthcare is operating, and health plans are operating in all different kinds of ways. It's really understand the flux that's occurring within the healthcare environment. Once upon a time, there were very defined and limited settings to deliver care, basically in a hospital or a clinic. What many of you know now, we have mobile technology, we have telemedicine, we serve people in homes, in schools, all these ways that really add much more robust array of services to what's possible. Once upon a time, addictive disease was seen as a moral failing, character flaw. What we know now, experts, and I think even average citizens come to understand substance use disorder as a treatable chronic illness. Once upon a time, who made the decisions about your health care in behavioral health, mental health, substance use disorders was a professional or a decision maker. This has changed radically, and I'm really proud to say Georgia's been a big part of what we call the peer movement, which is people receiving services have an awful lot to say, as they should, about the kind of care they want. More changes. Old world view, your health record was owned by your provider. This is true for you, even if you're not receiving behavioral health services, right? We expected your healthcare provider owned your information. The current reality is that we as patients, in any kind of healthcare we receive, we expect that it's our information. We want ready access and we want ownership of data about us. Old world view, to some degree, which still exists. If people with mental illness commit a crime, jail is the place they need to be. Well, Georgia is leading the way in a host of accountability courts, diversion projects, and really many law enforcement and judicial leaders who are saying we can do better. We can take a different approach to understanding crime, the intersect of crime and mental health. Mental illness and addiction used to be diseases of shame. Now you have younger generations that fully understand how to talk about mental health. I've had the opportunity in the last couple of years to visit my son's 5th grade classroom and then his 8th grade classroom. And you had a group full of kids who had no problem talking about mental health issues and substance use issues as if they were no different than diabetes, cancer, and heart disease. These youngsters are leading the way towards helping us to think about this differently. Once upon a time, prevention was seen as soft science. Hard to get people to make investments in prevention because you couldn't show immediate turnaround about what would happen. Now, there's unbelievable research about what happens to brain development in age 0 to 3 and what the impact of early intervention is. We have some experts in the room around that and folks that are really passionate. In addition, we didn't used to talk about trauma and the impact of trauma on what was happening on the lives of people who needed mental health and substance use disorder help. Now, what we know is that there is a growing expectation that trauma-informed care should be the standard of care. In our hospitals, we've embraced the opportunity to say, how can we deliver, even in a state hospital setting, trauma-informed care to individuals who really have been impacted by that in ways we didn't used to understand. So here we are, in a whole new landscape. We're going to go forward here. All right, so dramatic changes in the behavioral health landscape. I want to introduce two things that I think are going to be very important to our work going forward. The first one is talking about data. Where are we going to get our data? What are we going to do with the data limitations that we have? How are we going to come together and really acknowledge there are data limitations in our system, and that at times we're going to use different data sources. But I want to challenge all of us to think about how do we get good enough data to move decisions forward? How do we make sure the data that we have can incentivize us to make changes and not paralyze us? And you can see, I think you get the gist of what this map is, even though you can't drill down at a county level yet. But what you can see here is going to be another big theme that the commission will wrestle with, is workforce. So this is one snapshot. There are many more to come of health professional shortage areas in the Southeast. And what you can see is the large majority of counties in our state that suffer from a health professional shortage. We've got maps of every specific professional area, so there's lots more to explore. One of the reasons I wanted to show you the Southeast map is to make it clear the answer is not going to be to borrow from South Carolina or Alabama or Tennessee. While we do that, they're struggling in the same ways that we are. So this is really a driving force in the landscape, and I think we've already begun to acknowledge that as recognizing that workforce is going to be something that's going to shape how we think about solutions. Okay, next two slides are really some sobering trends, most of which many of you on the commission and folks in the room are very familiar with because this is what got you to the room. These snapshots, I want to acknowledge, these come from NAMI, who does excellent national work in production of materials to really make it clear to citizens all across the country about what the real impact is. So you see some of these sobering national trends. What we know is that 1 in 5 adults in the United States experience mental illness in any given year. 1 in 25 experience serious mental illness, and 17% of youth aged 6 to 17 experience a mental health disorder. But now let's look one level below that, or what are some of the system impacts here. Some of you are already very familiar with this. 1 in 8 of all visits to the emergency department in the United States are related to mental health and substance use disorders. 37%, and some folks think that's even low, of people incarcerated in state and federal prison have a diagnosed mental health condition. And here's where we get to some more painful realities, and this has brought other people I know to the room. Suicide is the second leading cause of death for people aged 10 to 34. That seems unbelievable. And in fact, the overall suicide rate in the United States has increased 31% since 2001. Last year, CDC produced a report. Every single state, except for one, showed an increase in suicide across every age category. It's a noteworthy public health problem. And in fact, suicide is the 10th leading cause of death in the United States. 46% of people who die by suicide have a diagnosable mental health condition, and 90% of people who die by suicide experience symptoms of a mental health condition. What you see on the map of the United States is really just to begin to ground our understanding of what are these illnesses. Lots more to discuss about what impact that they have, but you see the prevalence, the 12-month prevalence rate of each of these different disorders that require different diagnosis, different treatment, and really so beginning to understand what problem are we trying to solve, it requires us to become educated in some of the details here. So, now you knew what I was going to do, which is say these are national trends, but let's take a quick look at what some of the impact in Georgia is. So I want to show you this and give credit to Mental Health Association. Mental Health America is another national advocacy organization who in 2020 produced a national report, a state-by-state comparison, and ranked every state on a number of detailed measures. The report itself is excellent, complicated, but really what I wanted you to do, and we could, here's the point. You could argue the measures till the end of time, or you can take the information and say, these are legitimate measures, and I want to understand where Georgia stands. So you see the adult measures, and it's really assessing adults with various illnesses and the degree to which people receive and access treatment. So you can see adults in Georgia, Georgia was ranked 40th among states. The youth measures, again, similar, trying to measure what's the prevalence of some of these disorders and access to treatment, a little better there. Again, most children in Georgia have insurance, so that might speak to a little bit why our ranking is a little better there. So Georgia was ranked 23rd there, but I have to point you to the ultimate, the access. When looking at these particular access measures across the board, and again, I encourage you if you're interested sort of in how these actually get measured, but here's the bottom line that you care about and that I care about deeply. Georgia's ranked 50th in access overall. That is the problem I think we are really interested in solving. Understand why that is, and more importantly, how can we begin to solve that problem? So we've got strategies that the commission is going to undertake. I think I really just want to acknowledge and thank Chairman Tanner for saying, let's start first by trying to really define and understand the problem. We're not going to rush to throw things on the wall. These are challenges that have built over a long period of time, defining and then embracing. Embracing what's possible. What are the assets here in this state that we're going to be able to build on in order to make progress? And then my own perspective is that prioritizing how we're going to do this is going to be critical. For those of us who have sat on many commissions, task force, groups that were really intent on making a change, my own experience has been our lack of willingness to prioritize has often stood in the way. We end up with 1,000 recommendations and try to pursue all of them in saying, here's 5 or 6 and here's a pathway forward, and agreeing on that. So I hope that there'll be an opportunity to really take these big complex problems and really begin to prioritize what's possible. I think the subcommittees now we know are going to be an excellent starting point for how do we narrow the focus, how do we work in smaller groups to really think about how to get things done. And then what I know you'll find, let me go ahead and already preview, no matter what the issue is, in every state around the country, they're really looking at 3 things. 1, access. We know that's critical. If you can't get in the door, if you can't find what you need or get what you need, the rest doesn't matter. But if you can, it does matter, because we all want quality services. But you can get access and you can get high quality services, but if they're not coordinated with other services that you have and need, we're still not going to achieve the outcomes that we desire. So I think there's an opportunity just to know that access, quality, and coordination are going to be a part of the solution. So, as I already previewed, I didn't come today with answers. I came with some questions. And really to get you thinking, as you'll hear from subject matter experts, you're about to get a lot of information. That's the information that's going to be from DBHDD's perspective. We well know the world is a lot bigger than what the public safety net does. So we've got to talk about how do all these things come together. So we get to who, what, where, and how. Easy questions, right? I promise you the questions are easy, but why I didn't bring the answers is because I don't have them. Together we're going to have them. But who are the patients? Who are the providers? Who are the practitioners? Who are the policymakers? Who are the priority populations that we are going to make a commitment, we are going to make a change for? What? What are the conditions that need to be addressed? Some of them we well know and they're well understood. Others less so. What's their prevalence here in the state of Georgia? What's the continuum of interventions and supports that folks need? What does the evidence say? And what about comorbidity with other health issues? Back to this point of behavioral health as part of healthcare. So on one hand, we're talking about individuals with serious mental illness. On another hand, we're talking about people with heart disease who have a high degree of depression. How are we incorporating that into our conversation? What does comorbidity mean? And what about individuals with serious mental illness and youth with mental illness who have other health conditions? How are we making sure that the whole health of an individual is being coordinated? Where? So what are the preferred settings for screening, identification, treatment, recovery? What does this look like in the community? And I think one of the most really critical questions that we have to face is, where do people enter our system and why? Why is that? So not just map where it is, why does it happen that way? This really is the core access challenge. And when you think about behavioral health services in the state, just like every other state, we have to come to an understanding about how services are organized, how they're financed, and how they're measured. And I really want to say a point about this word about how they're measured, right? Because we're going to have to get in this together. What does success look like when we start to make progress? For the last almost decade, DBHDD has often been judged by the measures that are in the settlement agreement with the Department of Justice. That is a very limited view of success. We all have lots more things than we want to accomplish than was set forth by a group of lawyers 10 years ago. Social worker commentary. All right, so just back to opportunities and challenges. Oops, sorry. Technical failure. Are you helping? Oh. So you already know what some of the challenges are. You heard them. You know stigma still exists. Despite the progress that we've made and a room full of people want to talk out loud about behavioral health, stigma is still a very real issue. In addition, we have workforce challenges. Across the board, and you're going to see any number of detailed maps about how those are impacting us. I know my fellow commissioners of fellow state agencies, we all know some of the challenges we're experiencing in coordinating our mandates and our, that's okay. Just go to the last one. Last. You got it. There you go. We have a number of special populations that I think folks will be very interested in drilling down into understanding what's their impact on the system. How do we do that? And then we have to face the reality you all already know well, which is our resources are stretched to the max in Georgia and in every other state in the nation. So how do we utilize those? How do we expand? How do we leverage? And how do we do the best we can in order to maximize what's possible here in Georgia? Here are the opportunities. You see them. Us gathered in the room, that's the biggest opportunity that we have. Leaders in this state. We have a commission with legislative interest appointed by the governor, the lieutenant governor, the speaker, the chief justice. This is a moment in time that is unique. We have to take advantage of it. The other opportunity that we have here in Georgia, I can't say enough about this. We are known internationally for the peer movement that exists in our state. Peer services became Medicaid billable in Georgia before anywhere else, and we have the largest complement of peers in our state. These are people with lived experience who want to give back to others. It's really one of our greatest treasures in the state. We've got compassionate and willing judiciary and law enforcement. I meet them all the time. We're not on opposite sides. We're talking about the same thing. How do we get people in the right place at the right time? We also, another really important asset in our state is our university and technical college system, who we know is at the ready to begin to talk about training and workforce and what's possible when university and colleges get involved. And by the way, they've got a deepening interest as they see their students struggling with mental health issues and really have asked us all to come to the table to make sure we're providing services in that setting as well. So what have we got to do? Start with what's necessary. So for DBHDD, that's easy. We're sort of set forth in code, and the money allocated to us by the General Assembly tells us pretty clearly what's necessary for us to do. We manage the public safety net. So today you're going to hear an awful lot about what the public safety net is, why we're arranged the way that we are, and what it looks like from our seat. And then I'm really pleased that you'll get to hear from some other perspectives as well. When we talk about the public safety net, we mean our state hospital system, our community service boards, and Decal, which is our Georgia Crisis and Access line. You're going to get to hear about all of those and then really hear in more detail how it looks from the seat of a CSB CEO and from a justice lens. And this is how we begin to really shape a conversation. So as we start with what's necessary, maybe you're familiar with this saying, because you start with what's necessary, then you talk about what's possible, and that's what gets you to what's impossible and how you can overcome it. So I'm excited to do that with all of you. Very pleased to introduce your first subject matter expert who's going to talk to you this morning, Dr. Emil Risby. Come forward, Dr. Risby. Dr. Risby is the medical director for DBHDD, oversees our hospital system, and has a wealth of experience and knowledge, and I'm really happy to introduce him to you and let him share a perspective on DBHDD's hospital system. Sir.
Thank you, Commissioner. Chairman Tanner. While they're pulling the slides up, I'll go ahead and admit I was a little stressed and nervous this morning. And as a psychiatrist, I'm prone to neurosis. My wife's out of town, and so I had to figure out on my own what to wear. And I didn't realize how stressful that was, and it got to the point where I just had to put some on and leave. I would be late today. So hopefully this is okay. The commissioner said it looked okay, so I feel a little bit better. Take a little bit of the stress off of me. I'm going to talk to you about, I'm going to give you a high-level overview of our state hospital system and talk a little bit about our forensic system, because it's both inpatient and outpatient. And Ms. Johnson is going to really cover the crisis services for us. So I'm going to leave that part out for her. I'll touch on it just a tad. But most of it will be hospital-based and forensic service. So if we don't have slides, you have copies of this presentation in your packet, and I'll just start rambling a little bit. So the second slide, thanks, sir. Oh, we're good. I think we're good. It's not happening. Oh, there we go. First, our state hospitals. We have 5 state hospitals in Georgia. We have in Columbus, West Central Georgia Regional Hospital. In Milledgeville, we have Central State Hospital. In Augusta, we have East Central State Hospital. And you probably figured out by now that Georgia Regional Hospital Atlanta is not in Atlanta. Georgia Regional Hospital Atlanta is actually not in Atlanta. It's in unincorporated DeKalb County. And then we have Georgia Regional Hospital Savannah. And unlike Georgia Regional Hospital Atlanta, Georgia Regional Hospital Savannah is actually in Savannah. These are the services we provide in our state hospitals. As you may expect, there's a full array. Can I do it this way? There's a full array of psychiatric services that we provide. Psychiatric evaluations, all the different treatment modalities. Psychopharmacology is a big part of what we do. I'm not going to go over each one of these, but I just want to point out psychosocial rehabilitation. That's different in that that programming is specifically for our individuals with severe and persistent mental illness. That's the program. There's several different things involved with it. It's skills training. I call it home economics sort of training, things that will assist the person in their recovery once they leave the hospital, give them the skills that they need to be independent. So we have psychosocial training, psychosocial rehabilitation that we do in our state hospitals. I want to jump to the right-hand side of the slide that talks about medical. When a patient is admitted into the state hospital, we become that person's primary care provider. We have a lot of individuals that come with medical comorbidities. Some of these medical problems we know about before the person arrives. Some of these medical problems we find out after they get there. The point I want to make that is once the individual is admitted into the state hospital, the cost of their medical care shifts from the county of their residence to DBHDD. So whatever they need, surgery, antivirals, whatever they need, we pay for it. Okay? And if our chief fiscal officer was here, he could probably tell you how many millions of dollars a year that we pay for non-psychiatric care, just taking care of the medical problems of the individuals that come to us. Dental services. Each one of our hospitals has a dental clinic. And just like many of our patients have not paid particular attention to their physical health, they don't pay particular attention to their oral health. And so we have dental clinics at each one of our state hospitals. Of note, 4 of the dental clinics, 2/3 of what they do is outpatient. They see individuals with severe and persistent mental illness who can, I stand corrected, they see individuals with intellectual and developmental disabilities who have trouble finding a dentist in the community. So they come to our hospitals for that care. We're committed to this population of serving them their dental needs as needed. Many of you may know that the last state hospital that closed was in Thomasville. Commissioner Berry was the commissioner at that time. There was a lot of discussion about what would happen as far as the dental needs of individuals in that area of the state. And the commissioner said, we are dedicated to that group of Georgia citizens. The hospital will close, but the dental clinic will remain open. Okay? So a little known fact, the only place where DBHDD provides outpatient clinical care is in the dental clinics. We don't provide mental health care in the community, at least not DBHDD employees. Okay? I'm sure everyone already knew that. Okay? It's not happening. So I need to use a different one. Or can you advance one for me? Am I pointing it in the wrong place? Yeah. Point it there, okay. So this slide tells us the 3 program areas we have in our state hospitals. Now, contrary to what some people think is possible, we no longer admit children and adolescents into the state hospital. Have not done that in 10 years. Okay? Child and adolescent services, you'll hear a presentation from Dante later on the services that DBHDD supports for children and adolescents. But we still have an adult mental health service. We have a forensic service, and we have a small service for individuals with intellectual and developmental disabilities in a skilled nursing facility. We no longer admit patients to that program. And you'll hear from legal counsel a little bit later today to talk about why that is. Okay? Let me say a little bit of the difference between adult mental health and forensics, although most of you probably already know, just to be clear. Patients on our forensic service are sent by the courts. They've been declared incompetent to stand trial, and the courts send them to the state hospital for restoration. They're involuntary admissions. It's not the individual's idea to come to the state hospital and get better. A judge has sent them there. So these individuals are involuntary patients, and they are admitted in the state hospital under Title 17 of the Georgia Code, which is the criminal code. In contrast, on adult mental health service, most of these individuals will also, at least initially, come to the state hospital as involuntary patients. These are your 1013s, your certificates for involuntary evaluation, and some probate court orders. The vast majority of 1013 and probate court orders do not come to the state hospital. They are seen in the community. And Ms. Johnson is going to talk to you about the array of community resources that are available as part of our crisis continuum when she gives her presentation. But as the ultimate safety net, the state hospitals continue to have an adult mental health service to accept 1013s and probate orders. These individuals are admitted to the state hospital under Title 37 of the Georgia Code, which is the mental health code. Now, why is that significant? Because they maintain certain due process rights. Okay? They can request to be voluntary if that's appropriate. They can request their discharge if they want. Okay? The only way we could keep an individual in the state hospital against their will on the adult mental health service is we have to present a case to a probate court judge. So if we go to a probate court judge and show that the preponderance of the evidence suggests that this individual needs to stay in the hospital against their will, the probate court judge will dismiss the petition and order the individual released. Because we have to demonstrate above the preponderance of the evidence. We have to demonstrate at a clear and convincing legal standard to keep this individual in the hospital against their will. It's a civil rights issue or civil liberties issue. There are individuals in the audience that could talk about this, probably much more intelligent than I can, but I wanted to bring it up because folks often question why we're discharging someone. Isn't it clear that this individual needs to be in the hospital? Well, sometimes it's clear to us that the individual needs to be in the hospital as well, but it may not meet the legal standard of clear and convincing. Okay? And so there are people who leave the hospital and we think probably could have stayed a little bit longer, but something about the Supreme Court having some ruling about clear and convincing before you can take someone's civil liberties away. And that's probably a discussion much more deeper than what we want to talk about in this high-level overview. But I just wanted to let you know why there's a distinction and why there may be a disconnect between what we think and what can actually occur. Oh, shoot. There we go. So why are these hospital beds that we have? On the adult mental health service that I just finished talking about, we have 313 beds spread out over 4 different hospitals. Note that Central State Hospital does not have any adult mental health beds. It's only forensics. This is your state's maximum secure psychiatric forensic facility. Okay? We have 641 forensic beds in this, between the 5 state hospitals. Oops. Here we go. In Augusta, at the Gracewood campus, there's currently 97 individuals on the intermediate care facility for intellectually disabled individuals. Also in Augusta, there are about 25 individuals. I'm going to give up on this, Porter. Ouch. There are about 25 individuals who are, well, I can't do it, okay. 25 individuals on the skilled nursing facility, and we have one other skilled nursing facility that's here in Atlanta. There are about 23 people on that, in that unit. Again, we no longer admit individuals to that service. Okay. So let's say a little bit more about adult mental health services. Last year in FY19, we admitted and discharged about 2,100 people. Okay. I just have discharges here, and the number of discharges probably equal roughly number of admissions. This does not show the number of people who were evaluated and not admitted. That's a much bigger number. But these are actual admissions and discharges. Well, I have the median length of stay here because the average length of stay may not give you the correct sort of sense of the turnover in the state hospital. So we have the median length of stay, and in three of the four hospitals we have adult mental health, the median length of stay is about 2 to 3 weeks. Okay, they're not long-term patients for the most part. West Central, because it only has 40 beds, over time it's sort of just accumulated individuals that have needed longer lengths of stay, and so it's sort of become a unit for the more chronic mentally ill individuals. Okay? And so that's why their length of stay is much longer than what we see in the other hospitals. Now, where do people, or let me just say one other thing. There's a rumor that there's a lot of people that are just revolving door. They come in the state hospital, we let them go, they're out for a little while, they come back. This is our 30-day readmit. I want to thank Greg Hoyt for compiling this slide for me. We looked at our percentages of readmits starting from 2008 up to the present. And right now, our 30-day readmit is about 4% over the last, turn it. I'll just tell you, if you could change it for me, that'd be great. I can't even fix the, you know, they have all these remote controls at home for your different TVs. I just let them sit there. Our 30-day readmit, oh, I have a different pointer that I can use. If you could change the slides, that would be great. Oh, shoot. No, don't change the slide. If you change the okay, all right. 4% I think is about as low as we're going to get given our population. Okay? We attribute this low 4% to an emphasis on discharge planning. Okay? So at the state hospital, you just can't wake up today and say, I feel better, I want to go home today. No, you have to have a discharge planning process. And if any of you are interested in the gruesome details of that, you just get it off our website. We have a discharge planning policy for the state hospitals, and it's a little bit more intensive. So we want to make sure that there's a good handoff between you leaving the state hospital and going to the community provider and where you're going to stay, et cetera, et cetera. Okay. So I think we've gotten about as low as we can get. So we don't have this large number of people revolving in and out. There's some, but for the most part, we're pretty proud of our 30-day readmit rate, fairly low. Another rumor that you may have heard is that most people who are discharged from the state hospital go to shelters. Okay. Next slide. Okay. Here is the residents that discharged from July of 2017 to September 2019, which is the last time we put this data together. Almost half of the patients, when they leave the state hospital, go home with their families. We have another roughly 10% or so that will go home to their own individual residence. Okay. So most of the patients do not go to shelters. Of the 10 discharge residents, the top 10, shelter is number 9. So we do have some people that will go to a shelter, but a shelter discharge is a big deal for us. Before the treatment team can discharge someone to a shelter, it has to get approved by the clinical director of that hospital, and then the request comes up to the central office. I look at every shelter request. I look to see the circumstances of what brought the individual into the hospital. I look to see if the chart reflects that the person is stable enough to leave. I look to see if there are 3 documented alternatives for this person other than shelter and why it didn't work out. And lastly, it has to be the patient's request. It is unusual for someone to go to a shelter and not want to go to a shelter. Okay? And we try to discourage them from going. At some point, we have to let the individual make the decision. They want to go to a shelter, we'll support that. But it's the last option. Next slide. This is discharges from the forensic service. Can you back up one more slide? Go back to that slide. What I realize that's not really clear here is that this is off of the adult mental health services. Okay? So if you're using this slide later, referencing this slide later, maybe just go ahead and write on there AMH, adult mental health. These are the adult mental health discharges at the time of residence, not forensics. Okay, go to the next slide. Now these are the forensic discharges. About 70% or so of the individuals that go to the forensic service go to jail when they're discharged. Now, you might say that's a bad thing. It's actually mission accomplished. Remember, these are the individuals that were sent to the state hospital because they were incompetent to stand trial. They've been treated, we now feel they're competent to proceed, and then they go back to jail. We probably, in the range of 75, 80%, restore the competency, 75 to 80% of the people that are sent to the state hospital. You'll see here that there's a small number of people who are discharged and they go home with relatives. Most of those individuals are individuals that come to the forensic service, and then the court say, oh, never mind, we're not going to proceed with this, you can let them go. Okay. So if they have relatives that they can live with, we proceed with discharging them to home. If they don't, then we have to figure out what to do. If they can't go back to their relatives, they're homeless, And so we bring those individuals to our usual discharge planning process. We'll try to transfer them off forensics onto an adult mental health unit. Next slide. So let me just say a little bit more about forensics, because forensics is where the criminal justice system and our department interact. So how does this all work? At some point, a judge will be brought to the judge's attention that a defendant may not be competent to proceed. That judge will write an order for a mental health evaluation at public expense. If the order is written that way, it comes to DBHDD. We're the public expense part of the order. And so it comes to us, and we will assign an evaluator to go and see that person. The court may just want to know if the person is competent to stand trial. The court may also ask for criminal responsibility. In other words, is the individual okay to move forward now? And what was the person's state of mind at the time of the alleged crime? The customer is the court. We're not doing this for the prosecution or defense. We're friends of the court. We're doing it for the court. 98% of these evaluations are done in the jails. Last year we did about 2,500 or so of these evaluations statewide. I want to shift to juvenile for a second. In juvenile court, the court may ask for a competency evaluation. The court may ask for a behavioral health evaluation. Back in the old days, it used to be called study and report. The court just want to know, what's wrong with this kid? Evaluate this kid, tell us what's wrong with him so we know what to do. Okay? Note that there is no criminal responsibility evaluation in juvenile court. Okay? So in juvenile court, we don't do criminal responsibility, but we will do competency to stand trial. Almost all of this is done as an outpatient. Because remember, we don't admit kids to the state hospital. Okay? All right. Next slide. So, back up for a minute. Back up. Sorry, back up. Yeah. All right. Let me get back to this competency issue. If the evaluator on the adult mental health side sees the patient, sees the inmate, feels that the inmate is competent to proceed, they write that report, it goes to the judge, and we're done for the most part. We might be asked to testify if there's not a consensus, but for the most part, we're done. Now, if the evaluator says that the person is not competent to proceed, write the report. Usually, the defense attorney will enter a plea of mental incompetence. The judge will accept that plea, declare the individual incompetent to stand trial, and order inpatient psychiatric evaluation and treatment. That's the ticket to get into a forensic bed at the state hospital, that court order. Okay? All right. Next slide. 70 to 80% of the people that come to us on that court order will get restored to competence. And when they get restored to competence, they go back to jail, as I pointed out on that other slide. The average length of stay for an individual that comes to us and gets restored to competence is about 4 months. So if the sheriff drops him off, he knows that's going to be 3 to 4 months before that guy is coming back. Okay? It takes us about 4 months on average. We have to do a report to the court in 90 days, but they don't necessarily leave at that point. We decide what to do. We might want to wait a little bit longer. On average, it's about 4 months. Okay? I noted here SB 440 youth. The 440 kids are juveniles that are being tried in Superior Court. Now, I mentioned that we don't do criminal responsibility evaluations on juveniles unless they're in big boy court. So if they're in Superior Court, then we will do a criminal responsibility if the court requests that. They don't go into the state hospital, but we have a contracted facility, the Turner Center in Marietta County. It's run by CSB, Pathways, I think, where there's the inpatient facility for the 440 kids. So the 440 kids are juveniles in Superior Court. A patient who's been found incompetent to stand trial doesn't necessarily have to come to the state hospital. If it's a nonviolent felony, we can do it as an outpatient if the courts will allow it. We have one jail-based competency restoration program in the state, and that's in Fulton County. It's a contract with Emory University where they run a pod at the Fulton County Jail. The sole purpose is for competency restoration. The goal for that is to decrease the number of individuals from the Fulton County Jail who might have to come to this hospital. We've had some success with that, and be glad to talk more about it at a different time. Now, let's just say patient sent to the state hospital is not competent to proceed and is not restorable. I mean, after a year, Your Honor, it's not going to happen. We're not going to get there. He is non-restorable. The court at that point will do a third order, civilly committing the individual to inpatient hospitalization. Individuals that get that commitment order, or if they're found not guilty by reason of insanity, the average length of stay in the state hospital is about 7 years. Now, average length of stay. We have people in our state hospital who's been there 20 years or longer. Okay? So how does that work? There's something called a risk assessment. We'll do a risk assessment, and if our risk assessment would suggest that it's not a good idea for this person to be in the community, we will not recommend it to the court. Okay? They just stay in the hospital. If our risk assessment says it's probably okay for this person to start transitioning out of the hospital, the court agrees, the court will give that approval, and then we'll start discharge planning. And it'll probably take us another year or so to work on a gradual transition out. If we think that the person could leave the hospital because of the risk assessment, the judge may say, thank you very much for that information. You can bring him back now. Okay? It's the court's decision. Okay? We only make a recommendation if the individual can leave. Okay? All right. I would never question the court's wisdom on these decisions. They're called, got it. Last year I was in a court advocating for a young man to leave, and the judge was really impressed with the progress that he had made and said, Doc, I'm really impressed with how well he's doing. Sounds like we have him in the right place. Well, Your Honor, was hoping you would let him go, but at any rate, it is strictly up to the court. We make a recommendation. And at this point, we're no longer focusing on getting them competent to proceed. We're working on long-term recovery. Next slide. So, if we look at these 641 beds for forensics, 45% of them are filled by individuals that are there for competency restoration. That's those individuals with a length of stay of about 4 months. Those are the beds that are turning. Okay? 53% of those beds are filled by individuals who are civilly committed. Those are the beds that are not turning. These are the people with the average length of stay of 7 years. Okay? So what's our challenge? The challenge is the number of individuals that are getting civilly committed continues to grow. And as that percentage continues to grow, it's impeding on this 45% bar. And so there'll be fewer beds that'll be turning. Okay? And so the department is trying to get ahead of this tsunami. We're building a new 40-bed facility in Columbus, Georgia, to kind of help with this. But at some point, this trend seems to be continuing across the country. More and more individuals being found incompetent to stay in trial, long lengths of stay, decreased ability for the forensic hospital system to get people in and out because this group, this bed percentage starts to shrink up. What's this 2%? This 2% there is usually what happens is there's someone to be accused of some horrific event. And they're usually, they're clearly mentally ill. Usually they're in a small jail. And the sheriff will call and say, we got to bring you this guy. Okay? Not the shift commander, not the chief jailer, the duly elected sheriff picks up the phone, calls us, you got our attention, sir, we'll make it happen. We'll bring the individual, just put him in the car and bring him. Say, we got a bed, just bring him. we use the 1013 proceedings for that. We need to use 1013 proceedings for that. And on that Monday morning, because we almost always have this call on Friday at 4 p.m. or 4:30. So we just bring them in, and then on Monday we contact the district attorney and say, hey, can you run up to the judge's chamber and get us an order so we can keep this individual in the forensic unit? Because we don't want to go through probate with all that due process stuff. I mean, it just gets to be too much of a hassle. And usually it's not a problem. So we fudge a little bit, but it's for the right reason. Okay? Next slide. Now, I'm encroaching into somebody's time a little bit, so I'm going to be really, really quick. Forensic community coordinator. So when someone is eventually released, do we watch them? Do we track them? Well, it all depends. Okay? So if the person is not guilty by reason of insanity, and the judge gives them a conditional release, by statute, we follow that individual. And what does that mean? A minimum of once a month contact and an annual report to the jurisdiction that that individual falls under, if they're not guilty by reason of insanity. Some years back, Superior Court judges started outpatient civil commitment of individuals that they had initially made inpatient civilly committed. So when this first started, we tried to do a little bit of a pushback. Your Honor, the code doesn't mandate us to follow people you civilly commit in the community, so you're going to have to find somebody else to do that. And so the judge said, fine, he could just stay in the hospital. So we said, well, maybe we misunderstood what you wanted. What did you want us to do? You just want us to follow them like we do the NGRIs? Yeah, okay, we got this. We got it. Well, I thought you said the code didn't allow. We got the code, so don't worry about it. We got it. And so that started this system of us following people who are civilly committed by Superior Court. So what are the challenges? NGRIs, 4 years ago we had 135 in the community we were following. Now we have about 150-something people with NGRIs in the community that these community coordinators are following. About 4 years ago, we had about 50 outpatient civilly committed through Superior Court individuals in the community. Now we have about 160. So now we have about 300 and something people that we're trying to keep a pulse on. Okay? So it's starting to stress us out a little bit. Now, any Superior Court judge in here that has to want an outpatient commitment, relax. Just tell me your guy's name. I can tell you exactly where they are. Okay, we got it. But if it continues at this rate, we'll probably have to look at either having more outpatient coordinators or just some other process, pairing up with probation or somebody to make sure that we can keep tabs on all these individuals. Community integration homes. What are these? These are group homes run by the department. The DBHDD staff in those group homes 24/7. These individuals are closely monitored in the community by our staff. We know where they are, we know if they missed curfew, we know if they didn't make it to work that day, we know if they didn't make it to the school they said they were going to. We know right away. Okay? These individuals are closely monitored. These individuals that we think need a high level of supervision, or the court thinks they need a high level of supervision. For example, someone who says not guilty by reason of insanity on a murder charge, and we say after 12 years, he has good family support. Your Honor, we think this individual could go live with his sister or a group home near the family. And the judge might say, y'all losing your mind at DBHDD? He's not going to live with his sister. That same judge, if we say we want him to go to a CIH, would probably entertain that notion. Okay? And so they're precious. We have 11 of these homes statewide, 61 bed capacity, and we're going to add 2 additional ones in 2020. Okay? And then there are forensic apartments. They're actually run by the community service boards. The big difference is that there's not an employee in the apartment keeping tabs on them. There's an employee of the community service board at the complex sort of keeping an eye on things, but it's not the same level of supervision that's in the CIH. Where for these, they're Athens, Columbus, Rome, I forget where all four of them are, but they're run by the community service boards. All right, next slide. I'm gonna have to stop. You hear more about workforce shortages. The reason why I have dentistry up here at the top, because most of the other sort of disciplines, we can usually get a contractor, a vendor, a locums, or somebody some agency to provide us someone to help us in that area. It's very, very hard to find a dentist who's comfortable treating individuals with severe intellectual and developmental disabilities. Yeah. So if one of our dentists, and all of them are knocking on the door of retirement, if one of them gets run over by a 18-wheeler, that clinic might not be able to continue to operate, at least not full-time. And so that's why I have it bigger than the others. Next slide. I'm talking fast because I'm over my time. Just want to say that we do a lot of training in the state hospitals, a lot of collaborations with institutions of higher learning, and this is some of them here on this slide. All right. Sorry for going over. Questions or just exit stage left? Okay, I'm exiting stage left, and I'll be followed by Ms. Johnson.
As she's coming up, I'll tell you after this presenter, for the commission members, we will have lunch, so we'll let Ms. Johnson go, and then we'll have a lunch break.
There is nothing like being before lunch. I will be very efficient. Thank you, Chairman Tanner. That will help me be really quick and efficient. I'm happy to be here. Thank you for having me. I'm going to give you a very high-level overview, thinking that this is going to be a longer relationship and that we can talk in more detail at times to come. So a little bit about me really quick. I've been with the department for 9 years. I'm the division director for behavioral health. I have worked in public work with the state for the 9 years, but before that I worked in community settings. So I've been in private settings, nonprofit settings, and my whole career has been spent in this work. I started at age 21. Devereaux is represented here today at Devereaux. So I grew up in Georgia. I'm from Georgia. My high school is 5 minutes around the corner, and we used to play right here at Panthersville State, and our football team just won state championship. I come from good stuff. So with that being said, let me give you a little bit of overview. Next slide. So the Division of Behavioral Health is pretty much, I like to say it in easy terms, it's outside the hospital walls. So we're community-based. We have grown over the last decade. We have quite a robust book of business. You'll hear some of this in detail today. We have an adult office of mental health services. We have an office of children, young adult, and families, addictive diseases, deaf services, recovery transformation, which is where a lot of our peer work is housed, an office of supportive housing, and an office of prevention and federal grants. And then we have 6 regional offices across the state. So we don't do all of our work from our downtown 2 Peachtree office. We really rely on our region offices to work with our communities and our stakeholders across the state, because we really believe that that's where solutions are driven from. Next slide. So for today's conversation, I've broken up the division into crisis and then non-crisis. And so first we'll touch on crisis at a really high level. Georgia actually has a really robust crisis infrastructure. I had an opportunity recently to speak to legislators from across the state, across the nation. And in that opportunity, people want to know, how can we do what some of the things that Georgia has been able to do? So I hope that the commission finds opportunity to build on some of the groundwork that has been laid over the last decade. We have a crisis response system. So if you follow the left column on the slide, we have what is called a Georgia Crisis and Access Line. This is something that is very unique to Georgia. It is a 24/7 ability for any individual to pick up a phone, no matter where they are, no matter what day of the week, and no matter what time, if they are in a crisis, to be able to seek help and assistance.
We have a mobile crisis response dispatch that is for all 159 counties in the state. It is a mobile crisis team that responds to individuals with mental health and addictive diseases. When I talk about behavioral health, I should have said that from the onset, I'm talking about mental health and addiction collectively. We have a newer outreach from our crisis and access line, which is the ability to text to chat line. Dante will talk a little bit more about that, I think, in a high-level overview. And then we have an ability to have what's called a crisis bed management system. So when individuals call our crisis and access line, they may just want resources. They may just want information, but in many times they are experiencing a behavioral health crisis, and they're able to pick up the phone to get help for that. If that cannot be de-escalated over the phone or addressed in that mechanism, they are able to, our crisis and access line center, which is also housed by Behavioral Health Link, they are able to dispatch a mobile crisis team, which is a team of professionals, and it also includes a peer to go where that individual is in their moment of crisis. So our ability to then do what happens after that response is determine, well, what happens next? Does this person just stay at home? Was the crisis able to be de-escalated? What happens? And in some instances, mobile crisis then may have to make a referral for the individual to go into one of our crisis stabilization beds. So I'll talk about this next level of services here. So we have different options in Georgia. We have behavioral health crisis centers, which are our newer models. A behavioral crisis center consists of a walk-in component, temporary observation, stabilization beds. I'll drill down to this a little bit in a second. Crisis stabilization units are just where the beds are. And then we have state-funded detox facilities for individuals needing detox. The other part of our continuum is we have, of course, our state hospital beds, as Dr. Risby talked about, but we also have access to some private community-based hospitals that we contract with to help with some of our overflow. Next slide. So our Decal Crisis Access Line, like I said, is statewide. It connects callers with licensed clinicians and trained professionals who are able to assist the individual when they're in a crisis. It deploys mobile crisis. It manages entry into our crisis system. So those programs that I just hit on that I'll talk a little bit more in a second. It is for both behavioral health and individuals with IDD or intellectual developmental disorders. A lot of times there's co-occurring crises that happen across populations. It gives referrals to providers throughout the network. It is free and confidential, and of course, the mobile texting capability that I just spoke of. Next slide. This is a snapshot. Go back. This is a snapshot of our Decal crisis call center. It's kind of important to see because it's like a 911 center. Most people don't quite understand the technology and the resources that are put into this center, but this is something that is very unique to the state of Georgia. And most times you would pick up a phone and call 911 first. This gives you an opportunity to call people who are trained in what your crisis may be. Next slide. So it is based downtown Atlanta. They receive 650 to 1,000 contacts on most business days. It's a very busy place. Nearly 40% of individuals call for themselves. 6% are calling for someone they know, like a friend or family member, and 46% are professionals calling to seek support for an individual that may be in their care or their services. Professionals can call our Decal line from an emergency room, from a community mental health center, private psychiatric hospitals, family, children's services, from wherever. It is available to anyone literally in the state of Georgia. Next slide. We also have the ability to do what we call we call it a referral board. And basically, just to make it really simple, it's a way for us to know in real time kind of the traffic flow that is happening to the beds that we contract with. So either if they're beds in our state hospital, if they're beds in our community-based crisis stabilization programs, whether that's the crisis stabilization unit or the behavioral health crisis centers, it allows us to see in real time the actual bed capacity that's available. This is something that's unique to only the state of Georgia. Next slide. The function and the role of the board, I kind of touched on that, and for the sake of time, I'm gonna just go to the next slide. Some of the real good benefits, though: air traffic control of the referrals to the crisis system. It allows us to have data on volume and actual wait times in real time. It allows us to see the crisis capacity and the demand across the state at any given point in time. And then it allows us to ultimately have better access to services. And again, this whole process is a Georgia-specific model. We get state calls from states all over the country asking us, how did we do this and what are we doing here? Next slide. So I wanted to break down a little bit of some of those programs that were in the middle of the slide that was up before with the Continuum. Our crisis stabilization units, they serve as a residential alternative to inpatient hospitalization. So if we can prevent a hospitalization from occurring, that's what we would like to be able to do. They're community-based, medically monitored, but they're short-term psychiatric stabilization and detoxification services. Across the state, we have the capacity to house 71 youth. And then we have 245 CSU standalone capacity for adults. 509 total adult crisis bed capacity that when you combine our CSU and our BHCC programs. Next slide. So our BHCCs, behavioral health crisis centers, similar to a crisis stabilization unit, but a little bit more options are available. It has 24/7 walk-in access, so an individual can walk in at any point in time into one of these facilities. They can receive a psychiatric assessment, an intervention, or some type of counseling services. Interventions include temporary observation, mobilization of natural support systems, and successful linkages to the appropriate level of care. 264 BH bed capacity, 509 adult, and 96 temporary observation bed capacity. Next slide. Mobile crisis services is just what it sounds. It is meant to be a rapid response to someone who needs crisis services. We offer that. It is community-based, face-to-face rapid response, statewide services, available 24/7, includes post-crisis follow-up to ensure that there was linkage to the services that were recommended, can be available anywhere in the community. There's an example here in the orange box. And then other crisis assessment services can be done by those teams as well. Next slide. Woo, that was a really high level of the crisis part of the behavioral health system. There is lots of detail there, but I'm sure we'll have plenty of time to dig into those details. So our non-crisis services, so the rest of the behavioral health network. The key things that I think are important to note, behavioral health services are provided to individuals in their own communities, offering high-level quality services and supports through a very comprehensive array of specialty services. We provide statewide service delivery for the system that includes prevention and treatment of mental illness in adults, serious emotional disturbances for children, youth, and young adults, and substance use disorders for both adults and youth populations. We focus on recovery. We do believe that individuals deserve and can get to a place of recovery through a community-based care approach, providing the appropriate levels of service in the least restrictive settings as possible. We've spent a decade building up a very comprehensive community approach to care. Next slide. The department serves more than 130,000 people annually in the Division of Behavioral Health. We serve as the state authority for behavioral health. We do 100% of our work through a network of contracted providers. We are not direct care providers, but we do contract with a robust network of providers. We offer statewide prevention services that are designed to reduce risk and increase protective factors. And then we are the single state agency for Georgia as it relates to being able to get a lot of our substance use and prevention dollars. There are about 255 behavioral health providers in the state right now. We don't close the doors to new providers coming in. Providers have an opportunity to apply throughout the year, so that number continues to be a moving target. So approximately right now, that's what we have on the community behavioral health side across the state. That's inclusive of 3 groups of providers. We organize them in 3 tiers. Tier 1 is our community service boards. They are separate, and you'll hear from Cindy today, so I won't touch on that, but they act as our safety net part of the system. I'll save the glory and shine for her. And then the second tier is community Medicaid providers. This is our largest group of providers within our network, and they are Medicaid-only providers. And then we have specialty providers that offer an array of services. Next slide. So when I say we have services, what are those services? So we offer essentially 2 buckets of things. One of those buckets is what we call a core benefit package. So think about your health care insurance that you may have. Most of us have a certain set of benefits for your physical health needs. Our core benefit package mimics that, but for behavioral health care. So they're your traditional outpatient type things that you may think of. Psychiatric care by a psychiatrist, nursing care for medication, case management, individual, family, group counseling, case management services. So here's an example of some of those services that are in that benefit package, but it's a robust package, and we expect that our providers that were on that tier 1 and tier 2 offer this to anyone that is in need based on their level of care. We also have a pretty robust specialty service selection. So I like to think of this as our a la carte menu. So here are some examples, some of the things that may have been, some of you may have heard of, like Assertive Community Treatment Act for adult. We spent a decade building up that service, which is pretty much a large team led by psychiatrists that does the work in the community. So that's one example. Supported employment. One of the things that we believe everyone should have the right to are basic needs, like I want a job. And so if I have a substance use disorder or a mental health condition, it may be difficult for me to maintain a job, get a job, and then maintain a job. So we offer supports for individuals like that. And then, of course, if I don't have a place to live, then I'm going to have challenges in addition to my mental health issues as well as my substance use needs. So we offer an array of supports for housing as well. So those are just some examples. That's all the time I have today to be able to go over any of them, because I think that's my last slide. Told you, between lunch and me, I was going to make it work. All right. So I look forward to being able to talk with you all more. Thank you.
All right, we, for the commission members, there's lunch back in the break room, Chick-fil-A, if you would just pick that up. We'll take 20 minutes or so, give you time to get lunch, eat that lunch, and then we'll get started back. So we'll be in recess till then. All right, again, we appreciate everyone coming back, and we will get started back. Our next presenter today is Cassandra Price. She's the Director of Office of Addictive Diseases from DBHDD. So we appreciate her being here and look forward to hearing from her. So I'll turn it over to her.
Okay, so we're going to have a pop quiz to start out. So raise your hand if you have a family member, a neighbor, a friend of a friend that has right now suffering from a substance use disorder. Okay. Now raise your hand if you know someone who is in recovery from substance use disorder. Wow, isn't that amazing? Did you see that? That's the hopeful part of what we do, is that recovery is an expectation. And so a little bit about me. I am an addiction professional. I started my career with one of our community service boards, Highland River CSB in Rome. I still live in Rome. Yes, I commute. Yes, I have problems. And so I began my clinical journey about 2000, and I've been with the department since 2006. And I also have an MBA, so I have a little bit of business knowledge to kind of round out the clinical side. I'm going to talk to you a little bit high level about what we do in the state of Georgia related to mainly uninsured individuals who have a substance use disorder. And I'm going to be talking about treatment and specifically recovery services. And this slide is a representation of mainly what we do. This is kind of the nuts and bolts, but there are some provisions there, initiatives that aren't listed. And I'm not going to go through each one of them on this slide because I'll drill down in the next slides. It just gives you kind of the breadth and scope of about what we do. So we break it down into adult, women, and youth, and that's largely based on our block grant from SAMHSA. That's the Substance Abuse Mental Health Services Administration. So for adult, we have 24 addiction recovery support centers. Senator Unterman, I believe you are familiar with our, we call them ARSCs, Addiction Recovery Support Centers. We rebranded those. And they are places where people can go who are in either early recovery or long-term recovery to get the support services they need. They're not treatment centers, though. They're peer-led and recovery activities that are community-based. For women, we have a number of programs I'll go over, as well as youth. So I'll break it down to, we have withdrawal management. So we have 3 standalone detox services. We have the 24/7 oversight that has withdrawal complications and treatment interventions. We also fund 22 of the CSUs. We have a portion of those that Monica mentioned under our crisis system. We have residential treatment. We have 16 intensive residential programs. What that means is the treatment is done on site for individuals who need that. It's called an ASAM level 3.5. It's the highest level of care. We have 15 semi-independent residential programs. That's where it can be off-site or on-site. Individuals may begin to do some work at that point. We have 7 independent residential programs. These folks are largely getting aftercare services and are working in the community. Our recovery supports, we have the 24 recovery support centers, and we have non-treatment recovery supports, recovery, health and wellness, and other supports in this community. That's the crisis stabilization programs. We also have 7 transitional housing programs. They're step downs for the crisis stabilization. So those are short term, it's 7 to 10 days. If you have a psychiatric or a substance use disorder crisis specifically here, you go there for 7, 10 days to get detox. We only detox for alcohol, benzos, and opioids. And so that's just one thing to be really clear. We don't do stimulant-based detoxification. But a lot of times people come in there and they don't have a place to go back, and they're not stable enough to go straight into intensive outpatient. So we have this step-down program where they can step down from a CSU and get some 30-day support while they're getting engaged in intensive outpatient services. So women's treatment and recovery support services, this is where I started my career. So it's very close to my heart. So we have 22 providers who do residential program services. These are typically programs that serve women who have dependent children. They can bring their child to treatment with them from the ages of 13 and under. We get a large portion of that funding from DFACS under DHS. We're very, very grateful for that. We also get state dollars that were replaced back in 2008 when we had the Great Recession. The legislature was very kind to us in helping keeping those programs open. We have outpatient funds for 17 providers, and we have transitional programs to help women step down and save money and get jobs and find child care, all the things that you need to do. And these programs are typically long-term, up to 6 months, and longer if we can make the case for medical necessity. For youth, we have 2 adolescent intensive residential programs. And I know you're probably thinking, well, you only have 2. Well, I'll tell you guys, with substance use disorder, typically the ages of 13 to 17, we mainly see marijuana as our main substance. We don't see a lot of opioid, thank God, in this age group so far. So we have these 2 intensive residential programs to deal with that. And it's usually a lot of kids referred from DJJ, a lot of kids that have truancy issues and different things, but usually the marijuana diagnosis is part of that. We have the non-intensive outpatient services, again, 13 to 17. And the non-intensive outpatient is that list of core benefit services that Monica mentioned, that core package. We have clubhouses. Fun story about clubhouses. a few years ago. This is actually when Gwen was over our, we were not the division then, we were the division of MHDD-AD under DHR. So a little backwards history. And we had to develop quickly. We had a lot of budget changes with managed care. We had to develop a system to spend those dollars and come up with something creative. And literally, within a week, we developed these Clubhouse programs that myself and a coworker had been dreaming of. And these programs are really, they're clubhouses. They are for kids to come and get recovery supports. We call it kind of a bait and switch. And so they may be getting some clinical services outside of the clubhouse, but we have activities, outings, games, peer support, anything you could think of to destigmatize the issues that they have and engage them in services and make them want to be with their peers and to be in recovery. And if you ever visit one, you'll get my excitement, I promise. So my favorite topic of the day. Could you hear my sarcasm? And I don't mean it that way because it is a big issue, but it has kind of overtaken a lot of our work. And so when I talk about opioids, I'll always, and the Commissioner Fitzgerald always does this as well, it just makes the case that this is the crisis that has risen to the level of, because of the overdose potential, it is a huge, issue in our communities and in the federal government, everywhere. However, just to kind of bring us back down to what's really happening, alcohol is still number one. Still kills more people than any other substance. It's still the most abused substance. And we've seen a rise in methamphetamines and cocaine. So I just want to make sure people just kind of just are cognizant of that. But I'll talk about opioid use prevention, treatment, and recovery, and I'll tell you a little story about it. So we are the designated single state authority for Georgia for both mental health and substance use disorder. We had the state targeted response and the state opioid response grants that came down from SAMHSA. It's a total of $73.7 million. You're like, wow, what are you doing with all that money? Well, that's cumulative, so let me just put that out there and make sure that the funds source is really clear. This was the grants that started in 2016 under the previous administration. And so these funds are very, very specific that they had to be for treatment, prevention, and recovery, and with a high emphasis of medication-assisted treatment for those with opioid use disorder. So a little story is, in Georgia, we only funded 2 MAT, medication-assisted treatment programs for uninsured, 2 in Metro Atlanta at the time of this crisis. Now we have 21. So I think that's about 450% increase, something like that. So that's one of the things that we've done with that. But I like to tell that backstory so people get the emphasis of where we had to put the dollars, because a lot of states who have Medicaid expansion or have had a system already in place got to do lots of fun, great things that I'm very jealous of. They got to put all kinds of people in EDs. They got to do really innovative projects because they had that MAT infrastructure. In Georgia, we didn't have it. So we had to build from the ground up. And so I like to tell that so you get some idea of why we spent the money the way that we did. So this is the example of where we went from 2016 to 2019. So we added 19 new providers, a 950% increase, over 1,700 Georgians supported through MAT. And if you don't know what medication-assisted treatment recovery, or MAT is, it's the use of medications to support individual with opioid use disorder. Vivitrol, methadone, Suboxone, those are the typical 3 medications. There's some variations of ththose, buprenorphine, Suboxone, we kind of use them interchangeably. But they're there to support people. When you use opioids, especially for a significant amount of time and at a high frequency, you really change the opioid receptors of the brain. And I'm looking at doctors going, I hope I got that right. But it is very difficult. There are people who can go through abstinence-based treatment and do very well with opioid use disorder. But for most folks, especially with long-term and have used a significant amount, they need the support of medication. And that is an evidence-based practice in every sense of the word. And so that is where we put the majority of our funds. These are our addiction recovery support centers. As I mentioned, the state was very generous to support us through the legislature to expand those, but also with our opioid dollars, we went from 5 to 25, which is about a 400% increase. If you look here, I love this slide. It shows how many encounters that we've done through our emergency department peers, our addiction recovery support centers, and our warm line encounters. We have a warm line people can call for opioid use disorder. 20,023 since May of 2017 through August of 2019. That's a lot of folks that we're touching out there that's dealing with this issue. These are the prevention components, and they are not a tireless list. Our director of prevention is not, she just started today, so she didn't get to come and jump it right in today. She's new. But these are some components that were under the grant: a statewide media campaign, the naloxone education and training, and peer-assisted school transition program. And then this is another slide that I really like. So we've trained over 4,000 first responders. We've given out almost 4,000 kits. We've trained 11,000 citizens. We have distributed over almost 14,000 kits to everyone in the community. And look at our results. 1,892 reported overdose reversals. That's 1,892 people that did not die from an overdose. So I just always like to let that sink in, because that's very important for me personally, to know that we're out there making a difference and helping people reverse their overdose and hopefully get into treatment. So here's a few other things we did. The Georgia Recovers, and I'll talk about that. I think it's at the, let me see if it's at the, yeah, it's at the very end. So I'll talk about that in a minute. My last favorite slide. And then we have the State Emergency Department Initiative. So we have 18 recovery communities, those addiction recovery support centers, learning to work in the EDs, and we have some peers that work in several emergency room departments. We have a faith-based initiative. We're training 20 faith-based leaders on how to engage in their communities with substance use disorder. And the last one, my last favorite slide, I promise, is our first statewide stigma reduction campaign. I don't know if anybody has seen these big giant billboards, but we put 18 billboards up of beautiful people who are in long-term recovery for substance use disorder. And that's our wonderful commissioner up there at the press conference, and those are copies of the billboards. And then there's a website you can go to and hear each of these stories. And what this does is help us reduce stigma. It puts people out there saying, I did get better, and you can get better too. And that recovery should be the expectation. So I think that is just really what the hopeful message is. And we're just really proud of the people that are in our system that have gotten well. People outside of our system have gotten well, and we're going to keep trying to make other folks get well and recover. So thank you so much for allowing me to come and present today, and I will turn it over to Dante McKay.
Thank you. Good afternoon. My name is Dante McKay, and I'm Director of the Office of Children, Young Adults, and Families at DBHUD. Before I present today, I wanted to share two things about myself, and thank you, Mr. Chairman, and esteemed members of the Commission. First, I wanted to share that I am, long before I became Director of this office, I was a family member with lived experience. My dad lived with severe and persistent mental illness from my earliest memories until we lost him in 2001. And so I spent many years coming to Georgia Regional. He was a Vietnam era veteran, and so the pathway in was either through to take him to the VA or grading in either path. He may come here until he was well enough to return home. The second thing is, you may have noticed that I hobbled my way up here today. And so realizing that I had this big presentation on Friday, I was determined not to get sick or catch the flu. And about 8 p.m. on Saturday night, Murphy's Law showed up, in that my 8-year-old was chasing my 4-year-old, and I tried to intervene, and I hit my toe and broke it, I know one, maybe two, on the ottoman. And so now, instead of emphasizing, I'll stop before you break something or hurt yourself, I can say, stop before I break something or hurt myself. Okay. So, the Office of Children, Young Adults, and Families, OCYF for short, moving forward. The care continuum spans from prevention, early screening, all the way through to late intervention, and services all along the continuum. You've heard a lot about them. Mobile crisis would be one, or Georgia Crisis Access Line would be one that would span the continuum. But my office supports services and supports all along that continuum. This slide represents the payers in Georgia. It was stated earlier that most children in Georgia have a payer. And so this is a representation of that. DBHED has primary responsibility for children who are uninsured or have SSI Medicaid. That's about 11% of our population. And then about 44% have CMO Medicaid or managed care Medicaid. And then there's this relationship between the two agencies. So the agency on the left from your vantage point would be Department of Community Health. The one on the right is DBHCD. People churn in and out of different payer sources, whether it's private insurance, and private insurance is represented here based upon individual being underinsured or having their behavioral health benefit carved out. But they may go from private to managed care to uninsured, and DBHCD provides a safety net for those services. So there's a lot of back and forth. In addition to providing a safety net, we invest heavily in infrastructure, meaning that we create services that supplement or complement the traditional services that are available in the Medicaid service array. So CSU, Crisis Stabilization Unit, would be an example of that, and then I will present others in the slides to follow. So you've heard all about core benefit package. Monica talked about it, previous presenter, so I won't spend a lot of time there. Crisis services at the very bottom, you've heard about those. I won't spend a lot of time with those, other than to say that crisis stabilization and psychiatric residential treatment facilities are on the late intervention side of that care continuum that I mentioned. We have a number of specialty services. I will talk about a few today, those being our mental health resiliency support clubhouses, our school-based mental health program, Georgia Apex, system of care generally and specifically for Georgia, and youth suicide prevention. Okay. So Cassandra just talked about substance use clubhouses. We also have clubhouses that focus on mental health, and essentially it's a therapeutic environment where families can go to feel supported and safe to help with navigating challenges around being isolated or navigating stigmas, and they can receive supports in these areas. So it's kind of like a Boys and Girls Club with a therapeutic focus. And we have about 20 of those throughout the state of Georgia. The next I want to talk about is our Georgia Apex program, which is school-based mental health. Just out of curiosity, I wanted to see how many have heard of Georgia Apex, if you can show of hands. I'd say about 50% in the room, so that's good. I have a little work to do. So there are three basic goals for Apex: increase access, early detection, and increased coordination between community mental health providers and school districts. The program is now in its 5th year, And those were the goals when we launched the program, which started as a pilot and then it converted to a program, but those remain our essential 3 goals today. Apex applies a behavioral health approach to behavioral health. And so it's a 3-tiered model. Tier 1, which is represented by orange, focusing on universal prevention. Tier 2, which is blue here, focused on early intervention. And Tier 3 is focused on intensive intervention. And so the first tier, or the orange level here, is appropriate for about 85 to 90% of individuals. It is general behavioral health promotion, wellness, classroom observation, those sorts of interventions. And then tier 2 is early intervention. So this tier focuses on youth that are considered at risk. It includes things like individual therapy, group therapy, youth mental health first aid, and it's appropriate for about 7 to 10% of youth. Can I get you? All right. Thank you. So, and then tier 3 is where the name Apex comes from. So this is the apex of the pyramid. I'm often asked, what does Apex stand for? What is the acronym for? It is not an acronym for anything. It represents the top of the pyramid. It is appropriate for about 3 to 5%. So this is the stage where youth in school is in crisis. It is focused on individual therapy, group therapy, family. And I should say about the model, because I didn't start with that, but Apex is a school-based, meaning that it funds clinicians to be inside of schools, and it looks different across the state, but in some instances they're 5 days a week. In some rural communities, they may be there a couple days a week, but the model is focused on placing them there to be present when they're needed. Next slide, please. Apex can be organized into 3 phases, 1.0, 2.0, 3.0, and essentially that relates to how the program is funded. I'll say more about 1.0 in the slides to come, but the program started as a pilot, base budget about $9.5 million annualized. And so we were able to grow the program, and as it has grown, attracted additional appropriations. Apex 2.0 relates to the Commission on Children's Mental Health, which was about $4.3 million annualized, and then Apex 3.0, and one of Governor Kemp's first official acts as governor, invested further in Apex, and so that is $8.4 million. Next slide, please. And so when I talk about 1.0, 2.0, 3.0, this slide represents the growth of the program over the first 4 years. 2 things I want to share about the model. First, the department's funding supports relationship building, startup, and allowing clinicians time to build their caseloads. And the second thing I wanted to share about that is that we require the providers to bill for services. That allows the program to remain sustainable. Best practices says is if a clinician is able to bill for about 60% of their time, then that position becomes self-sustaining. And so if there's a shift in funding, then the program hopefully will not go away, as is typical the case when you have grant-funded solely school-based health programs. And so through this reinvestment, we were able to grow from year 1 ending 136 schools, in 9,600, just shy of 9,700 students served, to year 4, 436 schools, and just shy of 52,000 students served. For the very first time in year 4, we started to try to track the number of students that had access to the universal prevention tier of Apex. And so we were able to quantify that. And so that number is 319,000 students that had access during academic year 4. Next slide, please. So the next few slides, we'll talk about system of care, infrastructure, and system of care values and principles. And so these slides are not necessarily in order because it's hard to talk about system of care in order. It's made up of a lot of different things. But I will start with this slide. So system of care, as it was intended by the creator several years back, is to provide a continuous feedback loop between the local level by way of local interagency planning teams all the way through to the governor's office. And so that BHCC represents the Behavioral Health Coordinating Council, which is memorialized in Georgia Code, and local interagency planning teams at the local level, also memorialized in Georgia Code. And then the interagency directors team is a work group of the Behavioral Health Coordinating Council. So I'll say more about all of those in just a second. Next slide, please. So there's something that exists called the System of Care State Plan. We are in the, it's also required by Georgia Code. We're currently in the 3rd year of the System of Care State Plan, the existing one. Work is underway to develop the next System of Care State Plan. The group that created that plan is the Interagency Directors Team working on behalf of the BHCC. And this slide represents the current membership of the IDT. The IDT meets monthly to plan, coordinate, strategize, inform, and the Behavioral Health Coordinating Council that I referenced a little while ago meets quarterly. The BHCC is always chaired by the commissioner of DBHCD, and its membership includes commissioners, mostly advocacy organization family members, but mostly commissioners connected to Georgia's public safety or healthcare safety net. Next slide, please. Now, I usually start with this slide, but I wanted to, for this group, show the infrastructure. So these principles develop Georgia's infrastructure. And so system of care is a philosophy framework created by SAMHSA in the early 1980s. Since that time, it has evolved, but essentially it can be organized into 4 basic values and principles: spectrum of effective community-based services and supports, organized into a coordinated network, prioritizes youth and family voice, and is culturally and linguistically competent. And so based upon these came our framework, which is, in I guess, a formalized way to implement that, as well as those were the drivers for the System of Care State Plan. Next slide, please. The current System of Care State Plan can be organized in these 5 areas, which is access, coordination, workforce development, funding, finance, and continuous evaluation. The current plan has about 20 strategies, 64 action items. I want to remain at a high level overview. We could talk about it. As Monica said, we see this as the beginning of a relationship, so I look forward to talking about it in committee meetings. But the group has done a really good job in implementing most of those strategies and action items. And just to give you a couple examples of some things that came out of this current plan, it became really apparent that, folks have a hard time sometimes accessing the system. They don't know where to begin at their point along the continuum, whether it is justice related or child welfare related or generated by behavioral health. So we created a couple guides focused on navigating the system, one from the perspective of a family, one from the perspective of a young adult. Something else that we created was a inventory of workforce development, behavioral health focused trainings across the state. Who was doing what, to what degree, how frequent, trying to understand the cost of that. That inventory, the first round of that has been completed. And then also just referencing back to that infrastructure and the feedback loop. So local interagency planning teams exist all over the state. There was not a current chair list that now exists. And we've been trying to figure out a way, because most that chair LIPTs are volunteer-based. And it could be chaired by Family Connection, executive director, or a member of the local CSB. And so just trying to figure out a way to collect data on the children, families that they were serving without creating an administratively burdensome process. And so we have come up with the workings of a simplified data form that we look to pilot here shortly. Next slide. The other system of care related investment that the department has made relates to the Georgia Center of Excellence for Children's Behavioral Health, housed at Georgia State University. This center was born in 2011 through a SAMHSA demonstration project under the leadership of Monica Johnson. And it has continued over time. Through that SAMHSA grant, if you will, we realized the value of having such a center of excellence in the state of Georgia. And so we continue to build on that asset. There are only 12 center of excellence focused on behavioral health across the country, and ours is the only one in the Southeast. Next slide. And so some of the things that COEs do is for every SAMHSA grant that we've had, they have supported in some way, whether it's data collection or analyzing data, looking at comparing data sets across child serving agencies, so on and so forth. And so they also provide backbone support for that interagency directors team that I mentioned, organizing the partners, organizing the information, keeping us on task. And all of the child serving agencies have benefited from having a COE. For other partners that have come along that have SAMHSA grants, they also have in some ways contracted with the Center of Excellence to support that work. Next slide, please. This slide represents our suicide prevention activities generally, training initiatives, needs assessments, leveraging shared resources, policy guidance, statewide suicide prevention conference, and the development of the Georgia Suicide Prevention Plan. Next slide, please. But more specifically, suicide prevention efforts focus on youth. Georgia has a Garrett Lee Smith grant from SAMHSA. It's a 5-year grant, focuses on age 10 through 24, working with 3 partners, CSBs, Advantage Behavioral Health, Highland Rivers, and Viewpoint Health. But it's focused on training gatekeepers and putting referral processes in place, and technical assistance, among other things, to support the coalition work across the state of Georgia. Last slide. So I wanted to end with this video. You may have, if you're in Atlanta, you may sometimes see DBHUD on MARTA buses, that logo. You may have a chance to go to the movies and see a PSA that talks about the work of prevention. But I wanted to share this PSA with you if you haven't had a chance to see it. Please work.
Bob's life story. Age 22, college graduation. Age 30, marriage. Age 32, the birth of his first child. And this is Rob today, at 45. But the most important time in Rob's life? Age 20, when his story changed, because someone noticed warning signs of suicide. Sudden changes in mood, loss of interest, social isolation, putting things in order. If you're worried about someone, take action. Ask directly, have you been thinking about suicide? Intervene. Let them know they're not alone, that there is hope. Refer. Give them resources to get the help they need. You can help someone picture a different outcome. Learn more at dbhdd.georgia.gov or call 1-800-715-4225.
Okay, thank you. That completes my presentation. Thank you for having me today, and I look forward to supporting the work to come.
Good afternoon. So just of note, I'm wrapping up the presentations by the DBHTD team with the settlement agreement, and that's purposeful. Often you would think we would lead by talking about the agreement that's been so instrumental and has so much influence, but really, as you'll hear as I walk through our timeline, it is something we're aware of, but and something that we certainly work to comply with. But there's so much more that we're doing. The work of the department, the transformation of the system is well beyond the requirements of the agreement. So I'll give you a little context and history, but we'll at points reference things that you've already seen in the materials and the presentations thus far. Oh, and just by way of introduction, I'm Amy Howell. I'm Assistant Commissioner and General Counsel with the department. Been with the department for 8 years. Came from juvenile justice, growing expertise in systems that are under federal oversight, but happy to talk about the progress of DBHTD. So as history, DBHTD ended up under what we refer to as the ADA settlement agreement, so the Americans with Disabilities Act agreement, so settlement agreement with the United States Department of Justice. Really, the history of it is it started in 2009 with what we referred to as the CRIPA agreement, which was the Civil Rights of Institutionalized Persons Act. And that agreement with Department of Justice and DBHTD, or the state of Georgia, was around conditions in the state institutions, the state hospitals. And after entry in that agreement, the United States sent a subsequent letter of finding to Georgia around really our ability to transition individuals into the community and having enough settings to appropriately integrate individuals. And so we entered what we now refer to as the ADA agreement in 2010. There are a number of provisions that I'll talk about that were in that, what we refer to now as the original agreement. But in 2016, we reached agreement amongst the parties, so Georgia and the United States, Department of Justice, represented by Department of Justice, with the majority of the provisions of that agreement. So the provisions and requirements under that agreement are upwards of 150 requirements that I'll give you some context on, but the vast majority of those were met. And one thing of note, when Dr. Risby was making his presentation, one of the things that he commented on was the absence of children in the state institutions. In advance of the agreements, one of the things that the parties agreed to, and I'm looking at Gwen because she was there, she could do this presentation as well, was the agreement that children would no longer be admitted to state hospitals. So they are not, the ADA agreement only deals with adults, that's the scope of the agreement, but there are no longer kids admitted to state institutions as mentioned by Dr. Risby. So the next phase after 2016 in achieving the agreement amongst the parties around achieving compliance was the settlement, what we refer to as the settlement agreement extension. So the parties agreed that there were still some work to do. So out of those over 150 provisions, there were still some key areas that the department still had work to do with. And so we entered into what we refer to as the extension. And I'll talk a little bit about that, but the term of that agreement, so it was entered in 2016, the term of that agreement was that the parties anticipated that the state would be in compliance June 30th of 2018. At this point, the state has not exited the agreement. The parties have not agreed on exit. The parties filed a status update with the court in 2018, in June of 2018, indicating that there were still some measures that the state needed to demonstrate. And as such, oversight and monitoring by our independent reviewer continues. And so it's part of the reason that agendas for these meetings are approved by Executive Council for the governor. So now, in relationship to the actual provisions, one note, I know we're the Behavioral Health Commission, but I just wanted to make you aware that the settlement agreement and the extension do address individuals with developmental disabilities. So just as of note, we long since have ceased admissions of individuals with a primary diagnosis of developmental disabilities to state institutions. And part of the objective related to ADA was providing community services and supports for individuals. So we work towards a number of targets in relationship to both the original agreement and the extension in relationship to moving individuals into communities with the appropriate supports. In relationship to mental health, one of the things that you'll often hear us refer to in terms of what's termed the target population are individuals with severe and persistent mental illness. And they are coming and going from very specific environments. Frequently admitted to state hospitals, emergency rooms, chronic homelessness, or being released from jails or prisons. And so there's a number of areas of the work that we've done that are intended to target that population. And in addition, we also agreed to have the capacity to provide supported housing to individuals in that target population who meet that definition above, who have an assessed need for supportive housing. So in relationship to the original agreement, I'm just going to put this slide up as a point of reference of the areas of requirements in the original agreement that the department had to meet. If you reference back to your materials and the number of services that Monica Johnson presented, you'll see that this is only a piece of the work of the department. So one of the presentations that we have is a before and after. So the department before 2010 to today, and part of what you can get a sense of in that contrast is this was what was required of the department, in essence, because it was not there or not as robust. And if you reference back to the list of even core service and specialty services that Monica Johnson presented, you'll see what we provide to date is far exceeds those requirements in the agreement. And that's sort of back to my point of our objectives, as Dr. Risby mentioned, made me a little edgy, but that our objective is to do what's right for individuals, and that's really what leads. So the agreement is certainly something we seek to comply with, but in the end, the array of services, both in crisis supports, supports for individuals, is around what's best for people and support their independence and recovery. In relationship to the extension agreement, when I say that we were released from the vast majority of provisions, it really narrowed to a few core areas. And in relationship to mental illness, the key core area was around supportive housing. And so you'll hear us talk about supportive housing. And then a piece of that were housing vouchers, so the vouchers that help support people in living in the community, and then also bridge funding, which is a source of funding that the department provides to help people with elements of turning on gas and lights, other sorts of supports to just help their success and stability in those houses, in housing. And then the other, one of the other key elements in terms of the extension that was required pertains to investigations and quality improvement. So just called for us to continue to develop our initiatives in those two areas. So as I mentioned, I already mentioned the quality management, but one thing I mentioned earlier was that we do have an independent reviewer who monitors the department's compliance with the terms of the settlement agreement and the extension. And she's required to, her name is Elizabeth Jones, and she is required to produce what now under the extension agreement is semi-annual reports to the court. So there are data measures and other information that we provide around our compliance that occurs. So in conclusion, as I mentioned, that's the history of the agreement, but the work and the transformation of the department is far beyond what those requirements are. And as we look to the future, our goal is to continue to meet those requirements of the agreement, but to really go beyond and to be responsive around what's needed in Georgia, what's needed in the state. As Commissioner mentioned, it's an agreement written by lawyers. I'm one of lawyers, I like lawyers, but an agreement written by lawyers at a point in time, and the needs of the state have certainly been dynamic and changing, and so we are doing our best to be responsive and meet the requirements, but meet the needs as well. Happy to answer any questions if there are any.
Thank you. All right, thank you. Thank you again, Commissioner, for a great presentation from everyone involved. A lot of these areas we're going to dive a lot deeper into as we move forward with the commission, as it's already been noted, so a lot of information's went out today. All right, next up on the agenda, I believe we have the next level of service from my own Cindy Levi, who is the Avita CEO of the Community Service Partners that services the area that I personally live in and work in. So appreciate her being here. She's a member of our commission, and we're going to hear from her about an overview of the CSB boards through the state.
Thank you. Use this so I have hands-free.
Sure.
Okay, thank you. Let's see if I can work the clicker. I don't know. It's been a challenge today. Thanks, Chairman Tanner, commission members, and guests for the opportunity to share my passion for walking alongside of individuals that are in recovery from mental illness and substance use disorder. I'm Cindy Levi. I'm a commission member. I'm the CEO of Avita Community Partners, which is a community service board that supports the residents of Northeast Georgia and a representative of the Georgia Association of Community Service Boards. GACSB, let me tell you, in this field, there is a plethora of acronyms. And at our recent educational exchange, we actually had a competition to see who could identify all of the acronyms and what they meant. And we actually gave away cans of alphabet soup for those that were able to work through that. So GACSB is the Georgia Association of Community Service Boards. And it is the trade association for the public safety net providers of behavioral health and intellectual and developmental disability services in Georgia. Association membership consists of 26 independent providers, 24 of which are community service boards, plus Fulton County Behavioral Health and Harrelson Behavioral Health. Our website, as identified here, gacsb.org, offers a map to be able to locate services across all 159 counties. I just explained that GACSB is the trade association for the CSBs, or community service boards. But what is a community service board? Well, CSBs are an integral and essential part of Georgia's public system of care for individuals with behavioral health and developmental disabilities. CSBs are Georgia's public safety net for behavioral health. And as the safety net, we are charged with serving those most in need, those with serious and persistent mental illness, those that lack the resources to receive services and supports. Our primary customer is that person who does not have medical insurance or is on the state's Medicaid rolls. CSBs are public entities, instrumentalities of the state. You heard earlier about 3 different categories of providers across the state, Tier 1, Tier 2, and Tier 3. The CSBs are Tier 1, or comprehensive community providers. What that means is that we are charged with serving individuals offering a large array of services. Prior to 1993, I'm not going to go too far back in history, but 1993, the local boards of health provided developmental and all disability services to the public patient. In 1993, through Georgia legislation and House Bill 100, community service boards were established. The local boards of health were given the option of continuing to provide a range of disability services. Fulton and Haralson County Boards of Health opted to continue to provide these services. All the others opted to move to the CSB structure for providing these services. CSBs were established and began serving the public in July of 1994, so 25 years ago. Each CSB is governed by a local board of directors and holds contracts with the state of Georgia for the provision of behavioral health and intellectual or developmental disability services. I'm going to pass it off. And the map. You've seen this map once before today, and I believe that the first time that you saw it was to identify where the state hospitals were. To give you an idea of the state-level organization of its public system of care, this map shows that the state is divided into 6 regions, which are subdivided into 26 different catchment areas. As you can see, CSBs are a statewide network, and along with Fulton and Haralson, serve all 159 counties of Georgia. Each CSB is assigned a certain geographic area to cover. The more highly populated counties, like DeKalb, for example, one of our commission members, Dr. Joe Bona, is the CEO there, serves one county. Well, that's because there's so many people that are there. But just as an example, Avita, my CSB, listed as number 3 on the map, serves a total of 13 counties. So we cover 3,400 miles and serve the counties of Banks, Dawson, Forsyth, Franklin, Habersham, Hall, Hart, Lumpkin, Rabun, Stevens, Towns, Union, and White. We're in the Region 1 area of DBHDD, and there are 5 CSBs in Region 1: Avita, Highland Rivers, Cobb, Douglas, and Lookout Mountain. All CSBs are governed by a board of directors. The current board composition is outlined in Senate Bill 349, which was enacted in 2014. The county commissioner or commissioners, board of commissioners, appoint individuals from their county to serve on our boards and report back to them. Each board also includes elected or appointed officials. At least half of the board members must be either consumers of services or family members of consumers. As an example, Avita has an 18-member board of directors. The board makeup includes 1 representative from each of the 13 counties, 4 elected or appointed officials, and 1 what's considered an at-large member. And our board decided that we wanted that individual to be a person in long-term recovery. The number of board members is based on population size and the geographic area that's covered. The boards meet regularly and are policy-making boards. Avita's board meets 11 times a year, once a month with a combined November-December meeting. The board has a fiduciary responsibility and is responsible to hire and monitor the work of its executive, who manages the CSB. The board selects a qualified individual and proposes a salary within the guidelines provided by DBHDD, and then DBHDD reviews the credentials and proposed salaries and has the final say on the hiring of that individual. CSBs are held to extremely high standards. DBHDD monitors 13 categories of standards called Key Performance Indicators, or KPIs. They include access to services, crisis management, transitioning of individuals in crisis, engagement in care, substance use disorder treatment and supports, recovery-oriented care, administrative and fiscal structure, required staffing, audit compliance, suicide prevention, housing access, community coordination and engagement, and the use of evidence-based practices. At least annually, the Administrative Services Organization, ASO, Beacon Health Options, which is under contract by DBHDD, conducts audits of each of the CSBs to ensure conformance to the outlined standards and ensure that the documentation of services delivered match the services that are billed. Annual financial audits conducted by independent auditing firms are also required. We obtain provider numbers in order to serve the Medicaid population after undergoing a close scrutiny by the Department of Community Health, and we are licensed and monitored through the Healthcare Facility Regulation Division of DCH, Department of Community Health, to operate a drug abuse treatment and education program. We're also required to maintain accreditation through an international accrediting entity called CARF, or the Commission on Accreditation of Rehabilitation Facilities. To ensure that we are in conformance with all the standards of the entities just mentioned, CSBs also have care management departments within their own structure, which conduct internal billing and quality audits, monitor incidents, oversee health and safety matters, and manage the organization's corporate compliance program. So you can see there's very heavy oversight. Who does a CSB serve? CSBs serve individuals in need of behavioral health services across the lifespan, offering a continuum of care to meet the individual's needs where they are at the time. This includes children, youth, young adults, adults, and older adults. Services are delivered in the communities where people live. Outpatient clinics are strategically placed in the communities we serve for easy access to care. In addition, many services are also provided outside of clinic walls. It's not just in the clinic, but we go into the communities. The CSBs support Governor Kemp's initiative to enhance school safety and provide counseling services in schools, as Dante just mentioned, through the APEX project. As an example, Avita has mental health counselors embedded in 43 schools across Northeast Georgia. This makes services easily accessible to the students. The parents don't have to take off work, go pick up their child at school, drive them to an outpatient clinic, drive them back, miss a whole day of school, miss a whole day of work. It's just much more convenient, easily accessible to those in need. We also partner with the schools to provide training opportunities to their staff, faculty, and students regarding risk factors, warning signs, and protective factors for those students that are struggling. Suicide prevention programs and mental health first aid are two examples of these. We also work very closely with our law enforcement agencies and the crisis intervention team trainings. The CSBs are integral as we are providing about 20 of the 40 hours of training in crisis intervention team. We can't do this alone. It takes the whole community to support the individuals in need. We partner with all these organizations that are listed and many, many more. Georgia, like most states, continues to experience mental health professional shortages. Doctors and practitioners alike. But the CSBs work together to recruit and retain some of the best practitioners that are available. The services of a medical doctor, a psychiatrist, is required for the operation of every outpatient clinic. Some of the rural areas access physician services via telemedicine. And that, of course, is a wave of the future and really makes a lot of sense for providing access to services. When we have a shortage of prescribers, it really doesn't make sense to ask a physician to get in a car and drive 2 hours to a different location when it can take seconds with the click of a button. We support individuals across the continuum of care based on their needs. Emphasis is placed on providing high quality, low cost, and low intensity services, such as our outpatient core services. However, we also provide higher levels of care to meet the needs with the goal of stabilizing and moving them to lower levels of care. You can see a lot of different services that are listed on this slide, and not all CSBs provide every service that's listed here. We provide the services that we're contracted to provide. But let me see, I'm going to see how fast I can talk, and I'm going to go through a list of those services that most likely we provide. Individual, family, and group counseling services, case management, community support, psychosocial rehabilitation, peer support services, assertive community treatment, HIV and hepatitis C early intervention, screening and testing, substance use disorder outpatient clinics, community housing programs, supported employment, women's treatment and recovery residential programs, specialty services for the deaf with American Sign Language fluent counselors and case managers, emerging adult specialty services for ages 16 to 26, community support teams, accountability court programs, crisis stabilization units, behavioral health crisis centers, medication management services, autism spectrum disorder services, mental health clubhouses, and substance abuse clubhouses. Quite a range of services, I'm sure you'll agree. If contracted for a particular service, we must obtain an authorization through the Administrative Service Organization prior to providing those services. Without an authorization, we don't get paid. For many years, the Safety Net Behavioral Health System in Georgia operated in a grant and aid environment, where each CSB was funded at a certain level to provide behavioral health services and receive that funding on a monthly basis, 1/12 every month. But in 2017, that system was changed to a fee-for-service environment, whereby authorized services are delivered, and we bill to receive reimbursement for those services provided. The rate paid for each service is based on the Georgia Medicaid rates, which were established and implemented back in 2008. Each CSB is also given a cap or maximum reimbursement level for our funding. We will only be paid for services until we reach that cap. We are coordinating with many community resources. In addition to the direct services we provide, we also provide linkage to other supportive services that our clients may need. To highlight our most intensive service in the community and the 24-hour-a-day, 7-day-a-week access to care for individuals who are experiencing a mental health crisis or are in need of detoxification from substances, behavioral health crisis centers are available in some parts of the state. Now, we do not have these statewide yet, but there are behavioral health crisis centers located in Athens, Albany, Marietta, Decatur, Savannah, Thomasville, Griffin, and Valdosta. This is a goal, as was stated earlier, of DBHDD to secure additional funds for developing more behavioral health crisis centers. Community service boards operate 20 adult crisis stabilization units across Georgia and 3 child and adolescent units. Viewpoint Health, which serves Gwinnett, Rockdale, and Newton counties, is currently developing a crisis stabilization unit specifically for children and youth diagnosed with autism spectrum disorder who are in need of stabilization. For our individuals with mental illness, substance use disorders, and intellectual and developmental disabilities, we also provide wraparound services. Some examples include residential services and supports, assisting homeless individuals to obtain housing, supported employment, specialty court services, and linkage to transportation. Let's take a look at the numbers. In fiscal year 2018, CSB served close to 180,000 Georgia residents. As you can see, intellectual and developmental disability services for adults, a little over 5,000, mental health and substance use disorder for children and youth, 29,000, mental health and substance use disorder services for adults, almost 145,000 individuals. So how are we funded? CSBs have various partnerships for funding opportunities to increase access to high-quality services. We continue to work across the state to develop partnerships and seek funding opportunities which open up access to services and allow CSBs to provide more services in their communities. The data that you see on this slide is how CSBs are funded as a network, not necessarily individually. Each CSB may have slightly different breakdowns. So let's take a look at it. 42%, as you can see as the largest percentage, is with our state contracts. Next, we go to 35%, which is Medicaid. 15% is other sources, and those sources may include Veterans Administration, federal probation, jails, courts, schools, local, state, or federal grants, and fundraising through foundations. County contributions are 3%, and 5% is private insurance or Medicare. Are we a provider for Medicare and commercial insurance? That's always a question that's raised. Let me explain to you that we would like to be the provider for all, but we are primarily charged with serving those that do not have insurance. When we have the capacity, we will serve those with Medicare and commercial insurance. There are some things that kind of get in the way, though. I mentioned to you that particularly in rural areas, we're utilizing a lot of telemedicine for our prescribers to connect to individuals. Medicare requires that there is a physician physically on site in the clinic in order to bill them for services. So if we do not have a physician physically present in a clinic, we can't bill services to Medicare from that clinic. A few of the challenges that we face. Well, I didn't say funding. I didn't put funding up there, but of course funding to meet the demand is one of our largest challenges because there really are more people that need services than can be served. The professional workforce shortage. Often, CSBs are the training ground for staff. We hire staff, we train them, we provide them with supervision, but unfortunately, it's difficult to pay a competitive wage when your reimbursement rate has not been adjusted in 12 years and our costs continue to increase. There is limited access to affordable housing for those that we serve. And with most apartment complexes, they're now requiring criminal background checks. And so if a person does have a criminal background, it's very difficult to find housing for them. We also continue to battle the stigma associated with mental illness and substance use disorder, although it's wonderful that the conversation is started. CSBs are committed to being part of the solution. We're honored to be represented on this commission and look forward to our work together as we embark on a comprehensive review of the behavioral health system and advance our shared goal of promoting the continued progress of Georgia's behavioral health system. If we can provide any additional information or clarification on how to access services at CSBs, please don't hesitate to contact our association executive director, Robin Garrett. She's in the back of the room, and her contact number is provided. I'm providing that because she can give access to all of the CSB information. We would also love to host a tour for anyone that would like to visit a CSB. Just let us know. Thank you very much.
All right, thank you. Our last presenter today is no stranger to most of us, but Justice Michael Boggs had co-chaired the Criminal Justice Reform Commission for about 8 years or so, and we've become known as a national leader across the country for the work that they did. Appreciate him being here, being part of this commission. Looking forward to him taking a very active role as we move forward around the criminal justice conversation and mental health. So I've asked him if he would to talk a little bit about how they reached success and how they took a really big issue and broke it down into manageable pieces. So Justice Box.
So thank you, Kevin. I'm honored to be with you today and appreciate the opportunity to serve on Governor Kemp's commission. As the chairman suggested, tackling an issue in the area of public policy that is as deep and as broad as the behavioral health issues in the state of Georgia is tough, but it's not unprecedented. As we've now exited 8 years of criminal justice reform in Georgia, starting in 2011 with Governor Deal's 24-member commission, through 2018, we had 7 legislative sessions, 11 bills that were passed, and I will tell you that reaching consensus was not as difficult as we thought, right? So we started off with this concept of how do we tackle criminal justice reform in a really responsible and a meaningful way in Georgia that would not only, as Governor Deal put it back then, ensure that we held individuals accountable, but also save taxpayer money and improve public safety. And so as we think about that as kind of the model of how you might engage in effective public policy reform, I will tell you, anecdotally, having served 4 years in the Georgia General Assembly, I've gotten more done since I left than I ever did when I was there. And you know, that's not nothing, right? So when you think about how would you eat an elephant one bite at a time, and you start thinking about, as I was sitting here, reminiscing and thinking what the non-lawyer members of the Criminal Justice Reform Council must have thought, Mary Margaret, when we started criminal justice reform. As I'm listening to acronyms that I'm not familiar with, as I'm listening to really an area that while judges, and I think I speak on behalf of most of them in the state, are quite familiar with issues of behavioral health, we see the manifestation of a lack of services in our courtrooms. And when I was a Superior Court judge, I saw that lack of services, lack in rural Georgia in particular of available services. And so on the end of the behavioral health spectrum is the manifestation of these problems into our criminal justice system. So let me just speak briefly about, you've heard a little bit about the problem. You've heard a little bit about today about the substance of the issue that we're going to be tasked with tackling. I want to talk a little bit about the methodology rubric. That is, how do you go about addressing something that is this enormous when it is in a public sphere that has a lot of different stakeholders, advocates, and others that have a diverse interest in the outcome. I know many people have worked for years in the behavioral health space. Nora Haynes is a personal friend of mine, and I know that she's worked in this space for a long time. I will tell you that this is not going to be an easy task, but we didn't think criminal justice reform was going to be easy either. So let me just tell you, criminal justice reform required 11 bills over 7 legislative sessions. It required nonstop meetings. Most of the work was done in subcommittee, as I think the chairman has suggested might be done more appropriately here. We listened, we were very collaborative, which I think is an important aspect. Bipartisan, nonpartisan, collaborative, and very inclusive, and ensured that everybody had a say in sort of how we were going to address these issues. But having addressed that, you should understand, I'm a pragmatist, and I understand how hard it is to get public policy changed in this state. You have 236 legislators, all who are being pulled in multiple different directions by their constituents, who all have their own agendas about what they want to see done in the Georgia General Assembly. You have heads of agencies, many of whom are here today, who have a vision for where they want to lead their agency, but also understand the fiscal constraints that come with public policy. The budgetary constraints, of course, are very real, but so are the public and public policy and political restraints that come with any public policy reform. It is not coincidental that we were able to find concentric circles where they intersected and over 7 legislative sessions pass 11 bills with less than 10 total no votes. Most of those bills passed unanimously. And so as I want to talk to you about some of the pillars of success that we learned, when I talk about criminal justice reform a lot, we talk about the substance. What were we actually able to accomplish? What were some of the policy pieces that we moved forward? And they were many. and they are worthy of conversation. And I have a PowerPoint that I could have presented you today about where we were when we started and where we are now. And I think you would be proud as citizens of this state to know that your state is now a national thought leader in the area of criminal justice reform. But it didn't happen overnight, and it didn't happen easily. It happened with really a thoughtful approach to not just the substance, what were we going to address, but the story that I think is very, very seldom told, but I think deserves credit, is the how did we do it. I spent time at both the Obama and Trump White Houses talking to them about what we've done. The Justice Departments under both administrations has invited me to D.C. to talk to them about how did you do it. And the how you do it is, I don't think there's any secret sauce or there's any secret way to do this. The key is you have to be very thoughtful about your approach. And so let me give you some ideas about what worked in criminal justice reform that might be transferable to an organization and a commission like this that is tasked with a very deep issue. First, we work for the governor. It's his vision that we're attempting to advance here. And not unlike criminal justice reform that was Governor Deal's vision, the goal here is to advance the interest of Governor Kemp. Governor Kemp has an idea about how he wants to do all of this and what he wants to accomplish. And I think it's important that we make sure that we understand that leaving our own ideology and our own professional anecdotal stories on the sideline is important to make sure that we advance in a very thoughtful and respectful way the goals of Governor Kemp. In addition, managing expectations was tough with criminal justice reform. Everybody came to the Criminal Justice Reform Council with a story. Everybody came with an idea of how best to fix a problem. Very few people had data. Very few people had verifiable objective data, but they had these great stories about what works in one part of the state. I'll never forget, as we tackled reentry, how do we very meaningfully re-enter citizens from the prison system into their communities in this state in a responsible way. And this concept of reentry was thrust upon the Criminal Justice Reform Council, and it is meaningful. We release about 18,000 people a year probably into the state, from the state prison system into communities in Georgia, without temporary and permanent supportive housing, without jobs, without IDs, without wraparound mental health and substance abuse services. And is it any wonder then that we have a recidivism rate that is 30%? So of the 18,000 that are released, 6,000 were back within 3 years. And so as we tackled those issues, we had an individual from Ohio come down and explain to us that, well, it's easy. This is how you do reentry. This is how you tackle the reentry challenges in your particular state. Well, I don't know if any of you are familiar with Ohio, but Ohio has 88 counties. 88 counties. Other states came down, Kentucky, and so this is how you tackle it from a criminal justice, from a judiciary perspective. Well, Kentucky has a unified court system. Their Supreme Court controls their probation services, and it was much easier to do. So we have to think really about our particularized set of circumstances, and I think as the chairman's asked me to speak about this, and just thinking about how are we going to be successful, how do we ensure that the things that we tackle are going to actually move a needle and change people's lives, I think you have to, A, ensure that you understand who we're working for, but B, you have to manage expectations. We had a lot of people that came to us with really great ideas. We just simply weren't able to reach. And we weren't able to reach them for a couple of reasons. Sometimes it was political. Sometimes we couldn't get to an issue because we couldn't get consensus on it. We knew that ultimately our recommendations were going to go to the General Assembly, and we were going to have to get 91 people in the House to vote for it. And we wanted unanimity as much as we could, and consensus as much as we could. And we proved that we could gain that, but we did it by being very thoughtful about what we asked the General Assembly to take a look at. And so managing expectations was very important. The second thing that I think was probably one of the most fundamental pillars of criminal justice reform and ensured its success was that we were not based upon ideology. We didn't base our recommendations upon anecdotal stories or even necessarily some best practices in some certain parts of the state, but rather we based our recommendations on data. These data will inform the conversation, and if we allow the data to inform the conversation, I think you're going to find that we are going to be much more focused and have an opportunity for success, whereby if we don't, we're going to spend a lot of time talking about really interesting things that will never happen. So data drives the conversation. Commissioner Fitzgerald mentioned it earlier that we really are going to have a deep dive into the data. We did that with criminal justice reform. It provides political cover for 236 legislators. They know that this isn't just some emerging practice that we're asking them to codify into law, but rather this is a practice that has verifiable objective data that demonstrates that it works and it actually moves a needle. And so data, 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 and I will tell you that personally, from my perspective, that is the one fundamental thing that changed from my being a legislator and trying to make things happen to my being outside the General Assembly and trying to make things happen. And that is that you get away from being pulled into a conversation that maybe folks want you to be engaged in, for which there is no data. There is no data. And they all sound like good stories, and they'll touch your heart. And if you have any compassion at all, you want to help folks and you want to do these things. But listen, what's going on in the area of behavioral health across this country is not unknown to most of the people in this room. There are people that are making strides across the country. We can leverage what is being done, best practices that are being done across the country, and cherry pick the best practices to really emulate in our state. But data has to be at the foundation of all of those, or otherwise I think we'll be doing a disservice to the governor and to our other colleagues that are serving with us. The art of politics, I think, is the art of what is doable. I reiterate this in almost every speech I give, and that is that as we consider what it is we're going to be doing, and really limiting the framework of what we're going to try to tackle, we have to be very thoughtful about what is politically palatable. There were things we could not reach in criminal justice reform that I wish we had, that I had included in reports at the end of the year that I wrote. I would like to have addressed mandatory minimums. We just couldn't get there. I would like to have addressed some sentencing reform. We couldn't get there. The last report I wrote, Mr. Chairman, included an entire paragraph on behavioral health. We just couldn't quite figure out the best way to do it. And so that is why I am so interested in serving on this commission, because I think it is the next intuitive step of criminal justice reform, right? Governor used to say the best criminal justice reform was education reform, keeping people out of the system, all right? Keeping them in school, where my wife is a public school teacher, and I get it. Keeping them in school and out of the criminal justice system is the best criminal justice reform system you'd ever have. Well, what is the best system for the behavioral health system? Treat them in the community in a way that is wholesome and that is meaningful and it brings value to their life, and keeping them out of, ultimately, the criminal justice system or the state system in some form or fashion. But you have to be pragmatic about what is politically palatable. The sky's not the limit. You can't do everything. And so one of the things that we really did in compartmentalizing our work was we thought about how best to build political capital. So as we all, commission members, sit and try to chew on everything that we've talked about today and other things that we'll learn, one of the lessons we learned in criminal justice reform was baby steps. Bite off a couple of easy pieces that will build political capital and momentum. And as you build that political capital and momentum, there were things we did in year 7 of criminal justice reform that we could have never done in year 1. But we built this capital. We built confidence among 236 legislators that knew that what we were going to be recommending was based on sound data, not anecdotal stories, and not even what advocates necessarily wanted, but it was based on really good, hard, sound data. Not even always our data, but oftentimes it was our data. And so ultimately, political palatability is important. Compartmentalizing and prioritizing, as Commissioner Fitzgerald suggested, compartmentalizing and really prioritizing what you tackle and when is going to be very important. This is to coin a phrase, a marathon, not a sprint. We knew we weren't going to be able to do in criminal justice reform in 1 year everything that needed to be done. It took 7 years, and there's still work to be done. It took 7 years. There are still things I wish we had gotten to. And so as we think about our 4-year commission here and our role, you have to be thoughtful. I think we will be thoughtful about the things that worked in criminal justice reform. Some of that might work here. Some of it is not transferable. But I think some of it will work here. We addressed in criminal justice reform a broad spectrum of criminal justice policies. We started with reducing the state prison population. We went to juvenile justice reform, and if you can just imagine what that entails, included a complete rewrite of the juvenile code. We went from there to felony probation and misdemeanor probation. We created the Department of Community Supervision, so we went through regulatory changes there as well. And then we went into bail reform. All of those issues were not just intuitively grabbed because they were the next best thing, but we thought about at the beginning what we were going to tackle and how we were going to really prioritize those issues. And I think one of the lessons from criminal justice reform for me is that when you do it in that sort of fashion and you ground it on evidence-based practices or emerging practices at worst, I think you're going to find that we're going to have a lot of success in that regard. We're going to have some opportunities to make some significant changes here. I don't want to talk a lot about criminal justice reform because, that's that's then and this is now, but there are some lessons to be learned. And as you talk to legislators about, what their expectations are from us, I think you're going to find that most of them believe that, this is going to be a very thoughtful group and a very diligent group, and not only how we go about our work, but the types of things that we're going to be recommending. I guess, Mr. Chairman, that there'll be opportunities to address regulatory changes, opportunities to address fiscal changes, opportunities to address codified statutory changes. There are a lot of considerations that we're going to have, which is why these subcommittees, two of which really kind of directly deal with the criminal justice system, that is mental health courts and corrections. Involuntary commitments, not directly, but somewhat involve the criminal justice system. That's where my expertise is, so I'm really interested in learning from other members of the commission about how best to tackle some of this behemoth of an issue. But I'm encouraged, Mr. Chairman, with your leadership and with the breadth of experience that we have on this commission, that the lessons we've learned in criminal justice reform can be replicated here, in large part, I think, if we are very thoughtful about how do we approach our work, and that we're pragmatic when we understand that ultimately we have to get anything we recommend through a General Assembly, through the governor, and through any appropriations process, and none of that stuff's easy. And so I just want to say that I'm appreciative for the opportunity to serve, Mr. Chairman. I think some of the things we did in criminal justice reform will be easily transferred into a successful model here. People all over the country want to know how we did it. And I will tell you that people all over the country are doing it wrong in some instances. They're tackling criminal justice reform in a way that is not going to build political capital, that is going to ultimately not move a needle. And I hope you all share my concerns that ultimately what I hope we accomplish here is that we make a difference. And we can make a difference, but there is a template in the criminal justice reform story, I think, about how best to do that, and I look forward to being involved in it. Thank you.
All right, thank you, Justice Boggs, and thank you for all the work you've done over the last 8 years on criminal justice reform. All right, next on the agenda is subcommittee appointments for the chairman of those subcommittees. Like Justice Boggs said, one of the lessons I think that we all learned from criminal justice reform is we have a lot of different types of conversations that have to be had around mental health, behavioral health. In order to do those, we need to break those up into more doable conversations that we can take very deep dives into. So I'm just going to give you, I think, 3 or 4 of the subcommittee appointment chairmen of those subcommittees, and then we're going to send out an email in a week or so with all the assignments for all the members to what subcommittee. The subcommittee chairs will then work with me to put together agendas for those meetings, and those agendas will go back through the governor's office, just like this meeting. And again, like I said, I would anticipate we'll have subcommittee meetings every month or so, maybe more, depending on the subcommittee chairman's desires, and then full commission meetings every other month, and we'll try to set some dates for all of that and get them out to you. All right, and let me just say this, the legislation gives me the ability to name the subcommittee chairs, but it also gives me the ability to name 2 additional members to each subcommittee, which the reason we did that is we're going to be talking about some very, very specialized area that we may need some specific expertise on. So that allows us to go outside this group here and pick some folks and put them on just that subcommittee. They will not become full members of the commission, but they will serve on that subcommittee. So we'll also be making those announcements. And it also allows us in the law, there's 5 specifically mentioned, but it allows us to name additional subcommittees if we need to do that. But I think for now, those will be more than sufficient to get us started. The first one in the law is called Child and Adolescent Behavioral Health. We're also going to task that with what we're going to call early intervention. And she had to leave, but I've asked Dr. Sarah Vincent, who is a child psychiatrist, very well published expert in this particular area, to serve as the subcommittee chair in that area. And she's excited to do that. We've had quite a few meetings and conversations around ideas that she has, and as we're working to put together the members of that subcommittee, we have some very, very good members in this room who will make excellent members of that commission. And then we have a couple of folks that we'll be appointing outside the commission that I think will bring a great deal of expertise to that conversation. So excited to have her on board leading that effort. Involuntary commitment, I've asked Justice Boggs to chair that subcommittee. That's very much a legal conversation that needs to be had about how we commit folks through our probate court, when we can do that, and making sure that we're doing that in a very positive way, in a very legal way, but at the same time see if there's opportunities for changing that to make sure that when folks are suffering and family members are reaching out, that there is a way to bring that person in and get them the proper treatment and the stabilization they need in a more effective and efficient way. So, and we have some experts in that area with some of our Superior Court judges, with our probate judge, that I think can offer a great deal of expertise to Justice Boggs, and we'll also be adding 2 additional members to that subcommittee. The next one is hospital and short-term care. We're going to call that also access, and I've asked Dr. Brenda Fitzgerald, former Commissioner of the Department of Public Health, former head of the CDC, to head up that commission. Again, we have some other members that will be great assets to that. That's a very deep, difficult conversation around access. We'll also be adding 2 additional members to that subcommittee. I've also asked Justice Boggs to chair mental health courts and corrections, which is another one of our subcommittees listed in the legislation. I think it's a natural fit for him and some of the others in the room that live and talk about it and work in that environment on a daily basis. And again, an extension of what the Criminal Justice Reform Commission envisioned as a next step in addressing criminal justice reform. The last one's to be announced, still working on that one. That one's called Workforce and System Development, and talking with Commissioner Fitzgerald. And as you saw today, we know that that is a huge issue in this conversation. If we're going to be able to provide adequate services, and even if we make positive changes, we're going to have the people in place and the workforce in place to do that. It's not just, as the Commissioner's presentation showed, it's not just something Georgia's facing. I think that's a national problem, and definitely in the Southeast. So we're going to be looking at that and have some ideas about a couple of folks to help with that may be not in the mental health realm, but are in the conversation of workforce development and systems development in general, because a lot of these things around developing our workforce is broader than just one specific field. So bringing in experts to that conversation, I think, can be very, very helpful. So those are the subcommittees, and again, we'll get the all the members, which subcommittee you've been assigned to. I'm happy if you want to reach out to me if you've got some thoughts or suggestions. Some of you are very natural picks for a specific subcommittee based on the role that you play. Others could fit on multiple subcommittees. But we'll get that done in the next week or so, definitely before the end of the year. I'll be meeting with all the subcommittee chairs, and we'll be developing a timetable to get those subcommittees started right after the first of the year. We hope to have those meetings starting in January. We've got a lot of work to do, so we want to get started. People have asked me even today, I always have reporters ask me, what do I think about legislation? What do I predict about legislation? I will tell you, I'm entering into this conversation not putting that as the focus. Our focus is not, we got to have a bill, we got to have this, we got to have legislation. Our focus is we're going to improve the system. We're going to improve the outcome for the people who suffer, their families, and I think a side part of that will be policy changes, regulatory changes, legislation in the future, but we're not going to hamstring ourselves to that we got to have legislation by a specific date. The other thing I think that's going to be important is we're all going to have a lot of ideas. Those of us who serve in the General Assembly get bombarded with people who have ideas, but we're going to vet everything through our subcommittees. We're going to make sure that the subcommittees hear testimony, that they listen to the ideas, and that they recommend what moves forward, and then we'll take that up at the full commission so that we make sure that whatever actually gets to a recommendation to the governor and to the General Assembly has the full support of the subcommittee and from this commission, and that we're not just taking a shotgun approach to fixing this problem. So that's kind of the work forward, and looking forward to getting started. Wanted today to be very much about an overview and kind of wading out into the waters gently so we didn't drown ourselves. But moving forward, especially in subcommittees, we're going to be taking some very deep dives in some of these very, very difficult issues. I was down at, our Tanner Medical guy chairs the committee for the Hospital Association, and one of the folks, the CEOs in the room, laid out kind of the problem, and I remember telling them, I said, that's the problem. Now we got to figure out the solution. So all of us understand a lot of the issues we face. Finding the solutions are another thing. So we're looking forward to working with you on that. At this time, I'll entertain any questions or conversations or discussion. We didn't have take a lot of breaks today for that purpose, but I know a lot of our presenters are still in the room. They'll be available. I know Commissioner Fitzgerald and her staff's been great. They're available if you have any questions about anything you've heard today. Chelsea will also email out the presentations that you saw today, so you'll get those. Members of the audience, if you're interested, I know I had a couple of people ask, just get with Chelsea. The other thing I will tell you, non-commissioned members in the audience, if you want to receive notification about future meetings, including subcommittees, let Chelsea know or send me an email. We'll get you on our distribution list. It's also our policy to, if there are any public comments or anyone that would like to be heard, we don't have very much time, but we'll take just about 5 or 10 minutes. If there is anyone that would like to be heard by the commission, we'll do that at this time. Is there anybody here that'd like to be heard? If not, feel free to reach out to me personally at any time, and I know our other commission members feel that way. All the commission members, there's a tour that's going to be available for this facility. I would like to ask you to consider taking part of that. We're going to break up into 3 groups. Dr. Lee, who runs the facility here, is going to come up. He's going to give us the specifics of that, and I know that he has 3 different members of his staff that will be leading those groups. So again, I appreciate him, and I'll also remind you to please complete your citizen form that's in your file. We can't pay you for coming today if you don't complete that form. You only have to do it one time, and we'll take care of it from there. Contact information sheet and the confidentiality sheet that's in your folder. Please give that to Chelsea before you leave. Dr. Lee, if you want to come up, I'll turn it over to you to coordinate our tour, unless anyone else has anything. After Dr. Lee finishes, yes, ma'am.
Representative Tanner, I'd just like to remind everybody that Mental Health Day at the Capitol is February 7th, in case we don't meet prior to that. Love to have you guys here. It'll be hosted by the Behavioral Health Service Coalition, so just wanted to make sure everybody knew about that.
February 7th at the Capitol, Mental Health Day at the Capitol. All right, and Chelsea will send that out. Be nice if we could coordinate even a meeting around that. That'd be a great idea. All right, after Dr. Lee gives us her instructions, the official part of this meeting will adjourn, and commission members then will take his direction, and we'll have the tour. So again, thank you very much for being here and for your service.
Okay, we're so glad the first Mental Health Reform Commission has its first meeting in our hospital. As Commissioner Fitzgerald said, we are part of the state hospital system, and also we are part of the safety network for the state of Georgia. Actually, we are the safety net of the safety net. If a patient has no place to go, comes to Georgia Regional. So we serve the most challenged individuals. Our hospital has 3 adult mental health units, 3 forensic units, and also we have a admissions office, which is very busy. Every day, we have between 35 to 100 referrals pending, people coming to Georgia Regional. So it's going to be very busy. This afternoon, you will have opportunity to tour one of the 6 inpatient units. They all set up like very similar. So you'll see one, West Unit, and also you'll have opportunity to see the forensic, to the treatment mall. The treatment mall is a place for the patients to leave their living units during the daytime to receive the active treatment. So they don't stay on the unit all day long. And we have different activities, treatment in the treatment mall. And also you will have opportunity to see our admissions office, including a temporary observation unit. We call it a 23-hour unit. This patient will stay there for 23 hours for observation purpose, so that you will have a basic understanding what we do here. So now we're going to break into 3 groups, organized by your own, how you're going to divide it up. And I will lead one group. Dr. Risby will lead another group, and Tiffany will lead the 3rd group. And we have vans in front of this building outside, and we're going to take you to the units. Okay, thank you.